Okay, so let us start with the other forms of vasculitis, like one of the vasculitis that have been removed from the vasculitis, and it's not in the vasculitis classification right now, is the TAO. Zoom a little bit. TAO, that is thromboangiolytis obliterans, otherwise referred to as Buerger's disease. This is a different Buerger, Bueerger. Buerger's disease, thromboangiolytis obliterans. So this is also referred to as otherwise called as Winnie-Waters disease, that is W-I-N-I water. So that's called a Winnie-Waters disease. Usually it is common in males, and one of the exclusive cause for developing Buerger's syndrome or Buerger's disease is smoking. So smokers are at extremely high risk of developing Buerger's disease, typically in the age group of 20 to 40 years. This is the age where they typically get Buerger's disease, which means it's a young male. So they are the ones who are going to be affected. And why it is removed from vasculitis? Because there is no internal organ involvement. It's only limb ischemia, and there's no internal organ involvement. The basic idea of having a vasculitis is they will have an organ involvement. So that is the reason why we call them as vasculitis. And this TAO basically violates that basic principle of vasculitis. They don't have any internal organ involvement at all. There is no internal organ damage. They're going to cause only limb ischemia. Nothing else. You can ask limb is an organ or not, but limb as such will not be considered as an organ system. So only limb ischemia will be there in this guy. So usually you don't have any organ involvement. It's very difficult to diagnose Buerger's disease because it can coexist with atherosclerosis. That's why it's very difficult to find out. At the same time, you cannot take a biopsy really because it's involving the medium vessels like radial artery, brachial artery, so tibial artery. So they're going to involve the medium sized vessels, typically the radial, brachial, posterior tibial, popliteal. So these are the vessels that will be involved. So really you cannot take a biopsy from these sites. That's why it's a very difficult disease to make. And many times because atherosclerosis causing peripheral vasculitis is also going to coexist with this Buerger's disease, it becomes a very difficult entity to diagnose. So the most important DD, as I told you multiple times, whenever you think about a Buerger's disease, it's going to be the atherosclerotic peripheral vasculitis. The peripheral vasculitis is due to atherosclerosis. Because these patients are smokers, they can have an accelerated atherosclerosis. Because of that, you might get limb ischemia. So that's something which is very important to be ruled out. So that becomes an important differential diagnosis as well. Buerger's disease can be divided into three basic stages. So one is going to be the inflammatory stage. And second one we call it as the consolidation stage or intermediate stage. Third one, we have a chronic stage. So you have three stages in Buerger's disease. So inflammatory stage, what you're going to see is characteristically an occlusive thrombus you will see, but this thrombus will contain a lot of inflammatory substances like neutrophils. And because neutrophils are there, you might have abscess kind of a scenario. So the first stage, the most important stage, that is the occlusive thrombus that you will see. And this thrombus is basically an inflammatory thrombus. What do you mean by inflammatory thrombus? This is going to contain a lot of neutrophils in them within the thrombus. And this thrombus itself may show abscess. A focus of abscess may be there in the thrombus itself. So that's a typical inflammatory stage. Most importantly, at this stage, there will be no disruption of the internal elastic lamina. And that's one thing that completely differentiates this from other forms of vasculitis. So if you take other forms of vasculitis, there will be a vascular wall infiltration. Clear? So that kind of vascular wall infiltration is less commonly seen in Buerger's disease with inflammatory material. Rather than Buerger's disease, you will have an inflammatory thrombus rather than having a vascular wall inflammation. So that's why, again, they have removed it from vasculitis. And second, one of the key features of any vasculitis is disruption of the internal elastic lamina, where in Buerger's disease, you do not have disruption of the internal elastic lamina. That's why I told you that point in the giant cell arteritis where I showed you that Verhofstadt, where you are seeing the disruption of the internal elastic lamina, where here you do not really have the disruption of the internal elastic lamina, which clearly differentiates from other form of medium and large vessel vasculitis. And in consolidation phase or intermediate stage, you will see the organized thrombus. Thrombus will become more organized. There will be an organization of thrombus. So what do you mean by this organization of thrombus, which means they are going to be reduced inflammation in the thrombus that you have been seeing in the beginning. And third, in a chronic stage, you will be seeing only thrombus with no inflammation. No inflammation really exists at this stage. Thrombus only will be there. And there can be a vascular fibrosis. Vessel fibrosis will happen because of inflammatory damage. And during this stage, it's very difficult to find out. So this stage, even if you take a biopsy, that is completely non-diagnostic, because this can happen in many other conditions, including many other vasculitis. It can happen in atherosclerosis. So this is completely, non-diagnostic in the first place. Okay. So first two stages, if you want, you can diagnose, but in the last stage, it's completely not possible, even with the biopsy, because that changes can happen in any chronic conditions, including chronic vasculitis or long-standing atherosclerotic disease. So it's not possible. And what are the clinical features? And one more interesting thing in Buerger's disease, the characteristic fibrin necrosis that you will see will be absent. As I told you, the disruption of internal elastic lamina is not a feature of Buerger disease. And at the same time, your fibrin necrosis, which also defines this form of medium vessel vasculitis and certain other vasculitis, is characteristically absent in Buerger's disease. No fibrin necrosis, no disruption of internal elastic lamina, no typical vessel wall inflammation that you see in other forms of vasculitis. It's only a thrombus that's containing inflammatory cells. That is going to characterize the Buerger's disease in the first place. So clinical feature wise, typically they will have migratory thrombophlebitis. Many patients experience something called a migratory thrombophlebitis. This is not only seen in the setting of cancer, it can be seen in the setting of Buerger's disease as well. And this will certainly progress to limb ischemia over a period of time. That's going to certainly progress over a time to get a limb ischemia. And because of the limb ischemia, slowly and steadily, because of limb ischemia, patient will start getting claudication. Claudication, which is of course a sign of limb ischemia. So they will start developing claudication. And this kind of claudication is what we refer to as a typical instep or a pedal claudication, which means the patient will not get claudication first in the proximal areas. They'll first get claudication in the distal areas. That is typically referred to as something called an instep claudication or a pedal claudication, foot claudication in the pedal area. So this is a relatively specific finding for TO, but still again, none of this is specific to 100%. Everything can be present in other disorders also. Patients plus or minus may have Raynaud's phenomenon, which is also something very important to note. They might have Raynaud's phenomenon, and over time they will go for ulceration and gangrene, and they lose the limb. Ulceration and gangrene. And finally, it will come to a scenario where they're going to lose the limb. So most importantly, patients concerned again, different to that of a typical typical vasculitis. They are going to have a normal ESR and CRP. That's quite peculiar, isn't it? Having a normal ESR and a normal CRP. That's not very typical of a vasculitis. So that's why even in markers of inflammation, they're going to fare a little different from the typical vasculitis. The ESR and CRP will be quite normal. And there is no autoantibody in this situation. No antibody that is actually existing for Buerger's disease. Again, that is very peculiar. In vasculitis, majority of the times you have some underlying antibodies will be there. And biopsy is very difficult to take. You cannot really take a biopsy. Most of the biopsy specimens that reach the pathology lab are basically coming from the amputated limb. Only from the amputated limb you can take a biopsy. Even if you're taking from the amputated limb, it's not going to show any much change if the patient is having a chronic phase. So in the early stages, you can find at least, but in the late stages, you can't even find. And there will be reduced ankle brachial index. We know that this can happen in any other peripheral vasculitis. That's because, there is a difference in the pressures between the upper limb and the lower limb. Again, that's because of the obstruction that is happening in the lower limbs very commonly. So normal ankle brachial index is, we know it's approximately 0.9 or more than that. If it is less than 0.9, we can call there is some ischemia in the lower limb. Usually use this for peripheral vascular disease. This can happen in the setting of Buerger syndrome also, that is ankle brachial index. So when you do an angiography, typically we do a CT angiography, or even if you want, you can do an invasive angiography also. More importantly, their own characteristic finding is there. Again, this is not characteristic for Buerger's, but still, if you want to tell one characteristic finding, they affect only the distal areas. distal areas only will be affected, which will be occluded by thrombus. You will see the filling defect in the angiogram, which is characteristic of any obstruction, but it tends to spare the proximal areas. Even though it is said to be characteristic for Berger, you cannot take these findings as characteristic because this can be seen in atherosclerotic occlusions as well. And typically, apart from that, you will have other things like skip areas are very common in Berger's disease, and at the same time, you might see collaterals because it's a little long-standing disease, and these collaterals are characteristically referred to as something called a corkscrew collaterals. Corkscrew collaterals. All these have been described for Berger's disease, but none of these findings which I told you is absolutely specific for Berger's disease in the first place. So unless and until you prove that there is no active vessel wall inflammation and there is an inflammatory thrombus, plus at the same time there is no prominent fibrinous necrosis in the vessels, you cannot confirm it's a Berger's, which means biopsy is needed. Even biopsy only nearly says you can confirm, otherwise you cannot confirm. That is why we have different criteria for diagnosing Berger's. For example, if you take the criteria, there are two criteria. Everyone would have studied in pathology. We have one thing called the Shinoya criteria is there. And second one, we have something called Olin criteria. So two criteria are there for diagnosing Berger's disease. So as for both the criteria, the idea is very simple. I mean, nobody is going to ask you the, like what is the exact, like points that is given in the criteria. But both the criteria are based on only one thing. So that is, it should be a young patient, maybe less than 40, 45 years. And all patients should be smokers by default because smoking is the cause of developing thrombosis obliterans. And typically they should have distal ischemia so that there will be sparing of the proximal areas. And you should have absence of atherosclerotic risk factors. Atherosclerotic risk factors. The most important is the diabetes. If diabetes is not there, then you can diagnose. So diabetes mellitus should not be there. I mean, there are many points under these headings, but what I'm trying to tell is like both the criteria are actually based on these 4 points only. That is young patient who's smoker, having a predominant distal ischemia, and there is no major atherosclerotic risk factor like diabetes mellitus. In that setting, you can diagnose a Berger's disease, but it's a very difficult diagnosis to make. It will give you a huge challenge. It's not easy to diagnose unless and until you have a concrete information regarding Berger's. And that's also one reason they have removed this from vasculitis. It cannot be a vasculitis. If there is normal inflammatory markers, no prominent vessel wall inflammation, how can you put under vasculitis? As far as the treatment of Berger's disease is concerned, the most important treatment is going to be the smoking cessation, number one. The first is smoking cessation always. That's going to be on the top of the list. And you can use certain vasodilators. For example, you can use CCBs. You can use certain other vasodilators like PDE5 inhibitors. Those are nothing but sildenafil and tadalafil, phosphodiesterase 5 inhibitors. Prostaglandin analogs like iloprost have been tried. Then you have a non-selective phosphodiesterase inhibitor. I mean, that is typically used in the setting of peripheral vasculitis. That's called as cilastazole. And you can use another non-selective phosphodiesterase inhibitor like pentoxifillin. So all these have been told to be used in Berger's disease, but none of them have found to be extremely specific. Apart from that, I'm going to use clopidogrel also. It's better to avoid aspirin in this situation because aspirin can sometimes have a deleterious effect because of the decrease in the prostaglandin I2 synthesis. So that's why in peripheral vascular disease, more than aspirin, we prefer clopidogrel because aspirin can downregulate the PGI2 production. Because if it downregulates the PGI2 production, you might get more platelet aggregation and there will be a chance of relatively more vasoconstriction. That's why we don't use aspirin. Instead, we can prefer clopidogrel to prevent the accumulation of the thrombus. If there is a severe limb ischemia or if the patient is having gangrene of the limb, then there is no other option. You have to go for amputation only. Most of the Berger's disease patients, if they don't listen to us and if they don't really non-compliant to therapy or they continue to smoke, they end up in limb amputation finally. So this Berger's disease is very vague disease. It's very difficult to find out in clinical practice. Most of the time it has strong association with your atherosclerotic disease, but nevertheless, this is how it is. So, I mean, whatever I told in the criteria will be more useful for you because this is how in exam also you're going to diagnose Berger's. Young patients smoking actively predominantly distal ischemia, sparing the proximal areas, absence of atherosclerotic risk factors like diabetes mellitus, and mostly having a pedal claudication. That's called the instep claudication. And if they give some other findings like the corkscrew collaterals in angiogram, then surely you can diagnose Buerger's disease in exam. So let us see some images if possible. So I think we have seen this one. So this actually, I think I didn't show. This is an example of a coronary aneurysm. One of the examples of giant LAD aneurysm here, very big aneurysm. Of course, if this is this kind of image, if I see in the coronary angiogram, it's definitely diagnostic of Kawasaki disease. And this is an example of a Buerger's disease. So what I want to show is the patient is having predominantly a distal involvement, which means there's a radial ulnar area that is involved. So distal involvement is there where there is multiple filling defects in the angiogram. And apart from that, you can see this sort of collaterals. These are nothing but the corkscrew collaterals we are talking about. And at the same time, this is a typical distal ischemia resulting in gangrene of the fingers and the toes that you get in the setting of Buerger's disease. And this is one of the amputated limbs showing the vessel wall is okay. Relatively, the vessel wall is not, not having much issues here. But what you are seeing is a thrombus that is occluding the entire lumen of the vessel, but it's marked by inflammation. So this kind of inflammatory thrombus without much fiber node necrosis happening in the vessels is characteristic of a Buerger's disease in the first place. I think if you see the image, I think you will ask to remove my background image. So I think now you'll be able to see that. So you're seeing a lot of inflammation within the thrombus. Whatever I marked, these are the inflammatory cells within the thrombus, predominantly neutrophils. And this thrombus is occluding the vessel, of course. And of course, you are not seeing significant amount of fiber node necrosis or vessel wall inflammation very typically, like you see in other vasculitis. So this is typically Buerger's. Again, final take-home point in exam. Young, non-smoking, and no major atherosclerotic risk factors, and getting a distal ischemia predominantly compared to proximal ischemia, think about Buerger's disease. Let us move on from Buerger's disease. Not a very important question for exam. So then we are moving on to the small vessel vasculitis, because we have not yet discussed about small vessel vasculitis. Whenever you think about a small vessel vasculitis, the first thing that comes into your mind is the ANCA-related vasculitis and ANCA-associated vasculitis. So which means we need to know what do you mean by ANCA in the first place. So everyone knows the expansion for ANCA. This is nothing but anti-neutrophil cytoplasmic antibody, which means it's an antibody that is directed against the neutrophilic cytoplasmic components. That's all. Our cytoplasmic component of the neutrophils is what is going to serve as an antigen. So let us see what are the antigens. So there are some antigens that are associated with vasculitis. And there are some antigens that are not associated with vasculitis. Even they can produce ANCA. I'll tell you the importance of that in some time. Not associated with vasculitis. So what are the antigens that are associated with vasculitis? There are two major antigens that are associated with vasculitis. We know one is going to be the PR3 antigen, and the antibody that is generated against the PR3 antigen is anti-PR3 antibody. That's called proteinase 3, anti-proteinase 3 antibody. And another antibody is there, that is myeloperoxidase antigen in the cytoplasm. And the antibody that is directed against the myeloperoxidase antigen is what we refer to as anti-MPO antibody. Number two, there are some antigens that are not associated with the, vasculitis at all, which can be neutrophilic components still. There are multiple antigens there, and they can produce many uncharacterized antibodies, which means we don't know what their antibodies are, but there are a lot of uncharacterized antibodies, which is not really and clearly described in the literature. I'll tell you what is the importance of that uncharacterized antibody. So remember the fact that this anti-PR3 antibody, as I told you, will be associated with vasculitis. For sure, it will be associated with vasculitis, without a doubt. So surely this anti-PR3 antibody is associated with vasculitis. No doubt about that. But what are the vasculitis that are associated with anti-PR3 antibody? I have not still used the term P-ANCA and C-ANCA, so you have to be a little careful there. So that's why. So what are the vascularities that are associated with anti-PR3 antibody? But the most common vascularity that is associated with anti-PR3 antibody is going to be the vaginous granulomatosis, or I can write as GPA, granulomatosis with polyangiitis. But there are other vascularities, like for example, microscopic polyangiitis can be associated with anti-PR3 antibody to some extent. There's another vasculitis called as RLV. This is called renal limited vasculitis, which means this is a vasculitis that is going to involve only the renal vessels, especially the glomerular vessels alone. So that's called the renal limited vasculitis. Or you can have a EGPA. What is EGPA? Eosinophilic granulomatous polyuretha, otherwise referred to as Chug's-Strauss syndrome. Which means even though most common vasculitis that is associated with anti-PR3 antibody is vaginous granulomatosis, you still have other vasculitis to be associated with this anti-PR3 antibody as well, but in a small number. But as far as exams are concerned, anti-PR3 antibody always means vaginous granulomatosis. That is how they give in exams, but in reality, it's not the case. Similarly, as far as the anti-MPO antibody is concerned, the highest association with the anti-myeloperoxidase antibody is the renal limited vasculitis. That is where the highest association is there, which means it's a small vessel vasculitis of the kidney glomerular vessels alone. That's renal limited vasculitis. Apart from that, you can have a substantial association with MPA, that is microscopic polyangiitis. You can have a substantial association with EGPA, that is eosinophilic granulomatosis with polyangiitis, but a very poor association with that of your vaginous granulomatosis, that is GPA. You don't have a good association. But which means whenever you talk about a myeloperoxidase antibody, as far as exams are concerned, anti-MPO antibody, you are going to think about these three disorders, that is renal limited vasculitis, microscopic polyangiitis, and EGPA. But in the hindsight, if you see, all the four vascularities which I have told you are associated with either one of the antibody. In the sense, like, I'm not telling everything will be associated for sure, but it doesn't mean that particular antibody, if it's present, is specific for some vasculitis. So which means if there is anti-PR3 antibody, I probably think about a vaginous granulomatosis, but I cannot confirm it's a vaginous granulomatosis. If it's anti-MPO antibody, I can probably think about a renal limited vasculitis or MP or EGPA, but I cannot surely tell that it is one of these three vasculitis only. So what I'm trying to tell is this presence of this antibody surely tells you there will be some form of ANCA-associated vasculitis, which means there will be some form of small vessel ANCA-associated vasculitis is there for sure. I'm not denying that fact. But to tell what is the underlying vasculitis for sure, you need to analyze the clinical features and the spectrum of the disease, and at the same time, you need to take a biopsy. So without taking a biopsy and without analyzing the clinical features, just with the help of antibodies alone, it's improbable to tell what is the exact diagnosis, which means what is the exact type of vasculitis, cannot be delineated. But presence of these antibodies is very specific for vasculitis, especially ANCA-associated vasculitis. And if any of the antibody is present, you can be almost sure that there is some ANCA-associated vasculitis going on in the patient. That's what it can tell, but it cannot tell you the exact specific type of vasculitis. That's the one that is to be taken home. On the other hand, if you do an immunofluorescence, suppose what kind of immunofluorescence pattern that this antibody will produce. So like the same thing, like what we have done for ANA, I'm going to analyze in the same way. What is the immunofluorescence pattern that this antibody will show, that anti-PR3 antibody? Typically, they show a pattern called a C-ANCA type of a pattern. That's called a cytoplasmic staining. That's why it's called a cytoplasmic anti-neutrophil cytoplasmic antibody kind of a pattern. Whereas if you take an anti-MPO antibody, they can produce this kind of a typical P-ANCA type of a pattern. I'll show you what I mean by typical P-ANCA type of a pattern. But the problem is there are a lot of uncharacterized antibodies which can also produce a lot of ANCA type of pattern. These are called as atypical ANCA type of patterns, which means once again, our immunofluorescence will be sensitive, but it cannot be specific because immunofluorescence once again is screwing up because ANCA pattern can be associated with all these types of antibodies, need not necessarily be the vasculitis specific antibodies, that is anti-PR3 antibody or anti-myeloperoxidase antibodies. For example, if I give an ANCA immunofluorescence, it will be very sensitive to pick up an ANCA-associated antibody, but it will not really tell you whether it is probably an anti-PR3 or anti-MPO, or if it's even an uncharacterized antibody producing an atypical ANCA pattern. We have no idea. So that is why immunofluorescence you can use as a screening test. But once ANCA is positive, some form of ANCA is positive, it's always recommended to do an ELISA to find out whether it's an anti-PR3 and anti-MPO antibody. because there are a lot of uncharacterized antibodies that will be having underneath, which has no value in the setting of vasculitis. For example, what are the examples where you can see this uncharacterized antibodies? One of the important examples is systemic lupus erythematosus. We know in systemic lupus erythematosus, ANCA can be positive. I told you in the beginning of the pathophysiology of SLE itself, where nets are associated with ANCA production, but this is not a vasculating ANCA. This is some ANCA. We don't know what is that. It can be associated with rheumatoid arthritis. It can be associated with Sjogren syndrome. ANCA can be positive in this setting also, but again, these are not the characteristic anti-PR3 and anti-MPO antibody that we are looking at. At the same time, you would have studied inflammatory bowel disease. You would have studied that IBD can have ANCA association, especially, like your ulcerative colitis will have ANCA association, but they would have given P-ANCA is positive. But that kind of P-ANCA is basically an atypical P-ANCA. That is not a typical P-ANCA, which means that's not an anti-MPO antibody that is producing that ANCA pattern. That's an uncharacterized antibody. I'll come back to that. What is antigen? Then you will understand. Then you will study in your pathology that even primary sclerosing cholangitis tends to produce P-ANCA positivity. You would have studied. But what is that ANCA there? It's not the anti-MPO ANCA that we are seeing. That is a different type of ANCA. That is an atypical ANCA. Even though they give it as P-ANCA, that's an atypical P-ANCA. That's not a typical anti-MPO antibody that's producing that pattern. And even in autoimmune hepatitis type 1, you can get P-ANCA positivity. Again, that is not a typical P-ANCA, that is a atypical P-ANCA. And it can happen in the setting of a Felty syndrome as well, where ANCA can be positive. But that ANCA is again not a vasculating ANCA. That is a completely different form of ANCA that we are dealing with. So what is the idea here? So what is the antigen here? For example, if you take a rheumatoid arthritis, Sjogren syndrome, or probably Felty syndrome, the antigen against with these uncharacterized antibodies are directed are nothing but the myeloperoxidase and lactoferrin, which means it's not a very specific one because the antibodies are directed against this lactoferrin components also. So it's not a very typical kind of an anti-MPO antibody. When you take an inflammatory bowel disease, especially ulcerative colitis, you can see that the antigen against which these ANCA antibodies are directed is cathepsin G and probably elastasis. Against these only these ANCA are generated. These are also neutrophilic components only. And for primary sclerosing cholangitis, the antigen against this with these ANCA antibodies are directed is against cathepsin G again. Which means what I'm trying to tell is there are multiple other cytoplasmic antigens in the neutrophils against which your ANCA antibodies can be directed. But these ANCA antibodies are uncharacterized, and which means they do not really result in vasculitis. For example, take a primary sclerosing cholangitis. It's a biliary disease, isn't it? So it's an extrahepatic biliary disease where that causes thickening, stenosis of the extrahepatic bile ducts. So that is not related to vasculitis in the first place. And if you take a inflammatory bowel disease, you think ulcerative colitis is associated with vasculitis, despite the fact that they are P-ANCA positive. I don't think they are going to be associated with ulcerative colitis, by the way. Even if rheumatoid arthritis and Sjogren syndrome have P-ANCA or SLE have P-ANCA with them, that need not necessarily be the reason for the development of vasculitis in SLE or rheumatoid arthritis. The reason for development of vasculitis in SLE is other antibodies like anti-dsDNA, but these ANCA can be completely uncharacterized, and that is why the word ANCA should be used very carefully. So I believe that whenever you write in your case sheet, suppose if you suspect a vasculitis in your patient's diagnosis, it's always better to write whether what you want. You need an anti-PR3 antibody or anti-MPO antibody. I generally do that only. When I suspect a vasculitis in the case sheet, I'll be very clear. I don't write a P-ANCA, C-ANCA. I write anti-PR3 and anti-MPO antibody only because that is what I want. Because that is the one that is associated with vasculitis. If you just write a ANCA, if the report comes as ANCA positive, you cannot really take it as a vasculitis because there are a whole lot of other conditions which can also result in the development of ANCA positivity. But nevertheless, in exam, typical things really matters apart from the clinical practice that we make. Whenever C-ANCA, they tell in exam, it always means an anti-PR3 antibody. So it goes towards that kind of vaginous granulomatous. Whenever tell a P-ANCA, it always goes towards an anti-MPO antibody, which usually goes towards the diagnosis of microscopic polyangiitis or Chooks-Strauss syndrome. But in clinical practice, you have to be very, very careful that these ANCAs can be little confusing. So because many areas you will see ANCA, but that doesn't mean that particular ANCA is going to cause vasculitis in the first place. What are the vasculitic ANCAs? That's the question. Anti-PR3 and anti-MPO. Not the C-ANCA and P-ANCA you're talking about in reality. So if you see the ANCA pattern, so these are the typical ANCA patterns that you see. Suppose if I'm doing immunofluorescence and I'm seeing this kind of a picture. So this picture is very characteristic. You can see that this is the lobes of the neutrophil. This is the nuclear lobes of the neutrophils, which is not at all stained. You're seeing a cytoplasmic stain that is coarse, granular in nature. So this is typical of a cytoplasmic antinuclear cytoplasmic antibody. So what they are telling is it's a the name itself tells it's a cytoplasmic antinuclear cytoplasmic antibody, which means they didn't tell it's an anti-PR3 antibody. They just told it's a cytoplasmic staining is there. And because this antibody is directed against the cytoplasmic components, so we are calling it as a cytoplasmic ANCA. That's all. But one of the cytoplasmic antibodies is anti-PR3 antibody. There are a lot of other antibodies that can produce this kind of pattern, but characteristically, in the setting of vasculitis, the antibody that usually produces this pattern is anti-PR3 antibody. So that is why whenever I see this kind of a pattern, I assume in the setting of vasculitis, probably it should be an anti-PR3 antibody. For confirmation, I definitely have to do an ELISA, that the antibody that is present is anti-PR3. And at the same time, if you take this pattern, so this is the outline of the neutrophils. Here you are not able to see the neutrophils because the cytoplasm is not stained at all. Instead, this is the nuclei of the neutrophils, where only the peripheral part of the nucleus is stained, outside the nucleus in fact. So this kind of staining is a anti-neutrophil cytoplasmic antibody. Remember, once again, the terminology is very clear. You are seeing only a perinuclear anti-neutrophil cytoplasmic antibody, which means there is some antibody that is producing the perinuclear staining. And one of the staining is anti-MPO antibody. To be sure that this kind of staining is produced by anti-MPO antibody, you have to do an ELISA method to confirm it, because there are a lot of other antibodies that can produce this similar kind of a staining. So you have to separate them out. At the same time, you can see that these antibodies typically look like a sort of a popcorn. That's why this perinuclear antibody staining is also referred to as a popcorn kind of a staining. And if you see this particular staining, what do you think about? That's P-ANCA or a C-ANCA type of a pattern. What is that kind of a staining that you see there? It's easy, isn't it? So once you know what's happening there, you will be easily able to tell. So what is that kind of a staining there? Perinuclear staining or a cytoplasmic staining? Of course, it's a perinuclear type of a staining, but believe me or not, this patient did not have a anti-MPO positivity. This patient did not have anti-MPO at all. This patient, on the other hand, did not have any evidence of vasculitis, which means actually he was suffering from primary sclerosing cholangitis, actually. And even PSC can produce this kind of a staining pattern where there is absolutely no evidence of vasculitis. In fact, it came with the biliary obstruction kind of a picture. So that's why I'm trying to tell. This staining pattern alone cannot be specific for any particular disease. You have to do an ELISA method to tell what is the real antibody that is present in that particular patient. So that's a take-home point. Hope you get it. So write anti-PR3 and anti-MPO in case sheets if at all you suspect a vasculitis in your clinical practice. Clear. And again, remember this ANCA antibodies, if it's negative, it does not mean that you don't have an ANCA-associated vasculitis, which means it might be tricky to understand again. So ANCA-associated vasculitis means you don't have immunofluorescence. When you take a biopsy, you don't have any immune complex deposition. So that's where you typically call it as an ANCA-associated vasculitis, post-human variety. But what you have to take is there can be few number of vasculitis which may not have an ANCA. For example, if you take a Churg-Strauss syndrome, 40% of the cases will be ANCA positive. In that, almost 35 to 38% of the cases will be P-ANCA positive, which means we are talking about a MPO antibody. But 60% of the patients with Churg-Strauss syndrome can be ANCA negative, which means you may not be able to find out the ANCA, which means they can have the antibodies, but they are at very low titers, or there may be some other antibodies which are not going to predict. So that is why you have to be a little clear that presence of ANCA may tell you that patient is surely having some element of like ANCA-associated vasculitis, but if it is negative, it does not really rule out a smaller cell vasculitis. Even if it is negative, if the clinical features are certain about a vasculitis, you have to go for the biopsy, because biopsy is the ultimate confirmation. So that's what I didn't tell you actually, but it's something that should be taken home. In the vasculitis classification, we saw that angiography is supposed to be normal, isn't it? Angiography is supposed to be normal in a small vessel vasculitis. May it be ANCA or may it be immune complex vasculitis. But the most important point here is in small vessel vasculitis, especially the gold standard for diagnosis, of course, going to be the biopsy. There's nothing else that's going to be the gold standard as far as the small vessel vasculitis is concerned. Now, I think you will have a decent idea about what you mean by ANCA and how to use ANCA in clinical practice. And on top of that, on top of the confusion, even certain drugs can produce ANCA-related vasculitis. For example, your anti-thyroid drugs can induce ANCA and they can produce vasculitis. Like, for example, anti-thyroid drugs. Then hydralazine can induce ANCA. Minocycline can induce ANCA. Then there is a contaminant called levamisole is there. That is usually a contaminant in cocaine. So that can cause ANCA positive vasculitis. And usually in USMLE exams, that levamisole is a very common question because it's a common contaminant in cocaine. Cocaine is such a common drug in Western countries. It's used in most of the parties. So that levamisole, that is actually called as crack, that is mixed in the cocaine to increase the shelf life. So because if you take levamisole, it's not the cocaine that causes vasculitis, it's the levamisole contaminant that basically causes vasculitis. So drug-induced vasculitis. Think about antithyroid drugs. Think about hydralazine. Think about levamisole in cocaine, and think about minocycline. These are the 4 drugs that you need to talk about. So first ANCA-associated vasculitis that we are going to discuss is on the GP, that is granulomatous with polyangiitis. That's what we're going to discuss about. Remember, GPA is one disease that you need to know that it takes a subacute or a chronic course. And most of the small vessel vasculitis, especially ANCA positive vasculitis, may not have a very acute course like what you think in the exam. Clear? So in the exam, it will be coming very acutely. Like, for example, they'll be coming with sudden renal failure and they will have lung involvement in the form of hemoptysis. So exam questions will be like, everything happened all of a sudden. No, it doesn't happen like that. So usually, majority of the ANCA-associated vasculitis will have a very subacute course. They'll be happening for a long time, including polyposis nodosa, which will take so much of time to happen. Like they can have decades, in fact, 7 years, 10 years, 15 years of, like slow progression also we have seen in certain kinds of vasculitis. So it's not like all of a sudden. That is the point number 1. You need to know that it can be having a very commonly subacute to a chronic course. Apart from that, if you take what are the organs that are typically affected in granulomatous polyangiitis, you have 3 things. One is called ENT, lung and kidney. So we call it as ELK. I'm going to use a short form. So E stands for ENT, L stands for lung involvement, and K stands for kidney involvement. So from now on, you can write as ELK involvement. So let us see what are the characteristic findings in these 3 organ systems. ENT is supposed to be the most common involvement. Any vasculitis in exam with a prominent ENT involvement is equal to granulomatous polyangiitis, that is vaginous granulomatous, unless proved otherwise. Number 1. Typically, these patients will have sinusitis, and most of the time, this sinusitis will be chronic, and this is the most common presentation of a granulomatous polyangiitis. Remember, this is also the reason why majority of the patients will be under ENT care for a considerable duration of time before they reach out to the physician or to a rheumatologist. So sinusitis is the most common entity, and chronic sinusitis, most of the time, the features that happen in GP are basically necrotizing activity, in the sense like they'll be having a necrotizing vasculitis. So because of that, they'll be having a necrotizing sinusitis over a period of time. It's not like a typical allergic kind of a sinusitis, which means if you give your anti-allergy drugs like levocetirizine, that's commonly given for sinusitis, or give some asthma drugs, whatever, it's not really respond. So this sinusitis that is not responding to your routine therapy and it's worsening over a period of time, and it's necrotizing type in CT. So that time itself, an ENT physician should typically think about it could be a vaginous granulomatous or some form of vasculitis that is going on in the patient. But it's often missed. Patient will have a subtle course like a flares and then remission. They'll have spontaneous kind of activity like that. So it's often missed. They will think that the drugs what we give are working to the patient. So it will take usually a subacute or chronic course. Nevertheless, the most important point in exam is the chronic sinusitis. That's the most common way of presentation of your vaginous granulomatous. Apart from that, they can develop rhinitis as well. And this rhinitis will be necrotizing in nature. That is the reason why these patients can have a bloody nasal discharge at times. And if it is chronic, this rhinitis and sinusitis, if they happen in a chronic manner and if it's necrotizing in nature, they can result in something called a saddle nose deformity, because they result in collapse of the septum over a period of time, resulting in saddle nose deformity. And they can result in epistaxis as well because of the necrotizing nature, which is also quite common in patients with vaginous granulomatosis. And apart from that, they can develop oral ulcerations, which are again necrotizing in nature, and they can produce necrotizing gingivitis. And there can be like granulomatous reaction in the gingival area, so that you will be seeing that form of a hyperplasia of the gums may be there. That is because of the granulomatous inflammation that is seen in the gingiva, and that is referred to as something called a strawberry gingiva. I told you already. I think in Kawasaki itself we described that. And these patients may have a chronic pharyngitis. And this chronic pharyngitis can have a granulomatous type of nature. Granulomatous pharyngitis will be there. And these granulomas that are happening in the pharynx may result in obstruction of the eustachian tube. Eustachian tube obstruction. Because the eustachian tube gets obstructed, they can go for otitis media. Because of otitis media that is uncontrolled, they can go for a conductive hearing loss as well, which is also a feature of vaginous granulomatosis. They can result in deafness, and in a long run, they can go even for mastoiditis. Apart from that, they can have laryngeal and tracheal inflammation. Laryngeal and tracheal inflammation can happen, which can typically progress towards something called a subglottic stenosis. Very important point as far as vaginous is concerned. Subglottic stenosis. Very common question in exam. Vaginous can cause subglottic stenosis or not? Answer is definitely yes. They can cause subglottic stenosis and difficulty in breathing and all this stuff. And more importantly, they can affect the orbitals. I'll come back to that. They'll produce orbital pseudotumor. And let us see the picture. So this is a typical ENT involvement that we are seeing here. And you can see that this sinus is extremely thickened. In fact, both the sinuses are thickened, but this sinus is extremely thickened in this scenario. Thickening of the sinus, that is telling it's a sinusitis. A lot of areas of sinus are thickened, and in this patient, the left side is badly affected compared to the right side. And this is a typical example of a saddle nose deformity causing collapse of the nasal septum. And this is the typical strawberry gingiva that you see, that is because of granulomatous reaction in the gingiva, or granulomatous inflammation in the gingiva. And you can see this should be the usual size of the subglottic area as well, but you can see here there is a severe narrowing of the subglottic area. And this is a typical example of a subglottic stenosis, very important in vaginous granulomatosis. And next, moving to the lung involvement. As far as the lung involvement is concerned, there will be a chronic parenchymal lung inflammation will be there. Because of the chronic parenchymal lung inflammation, they'll go for granulomatous inflammation even in the lungs. And these granulomatous inflammation in the lungs will typically result in the development of infiltrates, and they can even go for nodule formation. In the X-ray, if they ask you what is the most common picture, that is the infiltrates. Infiltrates are the most common manifestation of vaginous granulomatosis in X-ray, and nodules are typical or classical. The location of the nodules makes them very specific. Usually these nodules will be located in the diaphragmatic surface of the lung, which means the lower zones of the lung. At the same time, more than 50%, half of the nodules tend to cavitate, which means this is an example of a cavitating lung lesion, and this cavity will be usually a thick-walled cavity. That is again characteristic feature of a vaginous granulomatosis. That is granulomatosis with polyangiitis. Ask you clinically how they present. The most common clinical feature is very subtle again. Is going to be cough. That's going to be very common in these patients, with or without expectoration. And after that, second most common is going to be the hemoptysis. Hemoptysis is not, the most common presentation, and that's what something to be noted of for. Rarely, if they become extremely severe, in extremely severe cases, rarely they can even progress towards something called a diffuse alveolar hemorrhage, DH. One of the important causes of diffuse alveolar hemorrhage is vasculitis. Even SLE can happen. You can get diffuse alveolar hemorrhage, but if it's severe enough and it's a severe vasculitis, you can end up getting something called a diffuse alveolar hemorrhage. And in like reality in a clinical presentation, how will you find out it's a diffuse alveolar hemorrhage? Usually in an exam, if they want to give you a diffuse alveolar hemorrhage, they'll give certain clues. That's very characteristic. One, they'll be telling you the patient will be coming with shortness of breath, plus chest X-ray will be having bilateral infiltrates. You might be thinking it's like an ARDS kind of a presentation, but they will clearly give hemoptysis. Hemoptysis is not a classic feature of ARDS. And when you do a bronchoscopy and you do a ball, you will get a bloody fluid, or you can call it as a bloody ball, bloody bronchoalveolar lavage fluid. So these are very characteristic features of diffuse alveolar hemorrhage, and the patient will usually have a background vasculitis, like constitutional symptoms will be there, which might be happening for a long time, like fever, weight loss, and the patient can have evidence of other organ involvement like renal failure. So that also might be the clue. If they give that, then it's easy to find out it's a diffuse alveolar hemorrhage, because I mean, when they have a renal failure, along with it, if they give this kind of lung involvement, so you know it's a pulmonary renal syndrome, so surely you will diagnose it's a vasculitis. So depending on ANCA, you will easily tell in exam. But if they give only this, then also you should be able to find out that it's a diffuse alveolar hemorrhage, and that's how they present with. And one characteristic question, like even though it's not important in real practice, but they generally tend to ask is, they will give a PFT, that DLCO. They will tell that DLCO is elevated to multifold. This is a characteristic finding again they used to give in the exams. The DLCO elevation is seen because that blood that is present in the alveoli, because it's a diffuse element, they tend to absorb this carbon monoxide so that it will look as if like your carbon monoxide uptake is so high and the diffusion of carbon monoxide is so high. But it's a spurious value. It's not a true value. It's basically a spurious entity, which means this DLCO elevation happens because this hemoglobin that is present in the RBCs that are present within the alveoli is the one that is causing this increase in the DLCO. That's all. So fine. So now we know the lung involvement. So characteristically, in severe case, you can result even in diffuse alveolar hemorrhage. Then go to the kidney involvement. As far as the kidney involvement is concerned, like it can be severe, but the most characteristic presentation is glomerulonephritis. That's how they present. We know the triad of glomerulonephritis, how they're going to present. They're going to present with AKI, they'll present with hypertension, present with proteinuria and hematuria. You know the proteinuria must be more than 500 milligrams per day, and hematuria typically will have RBC CAS. Why I'm writing again and again? Because you should be very, very thorough in that. Because these are very straightforward things. You should never miss in exams. RBC CAS is characteristic of a glomerulonephritis. And whenever there's a kidney involvement, when the patient is having AKI, unexplained proteinuria, of course, you will end up in doing a biopsy. If you do a biopsy, the characteristic finding, and the most common and the characteristic finding for ANCA-associated vasculitis that you see is something called the focal segment necrotizing glomerulonephritis. This is the characteristic finding that you will see. That's called a focal segmental necrotizing glomerulonephritis. And once extremely severe, you can result in the development of crescents called as crescentic glomerulonephritis. This is what in your pathology textbooks they will give as RPGN, that is rapidly progressing glomerulonephritis, but that term is not a correct term. It's better to use the term called crescentic glomerulonephritis, and that can happen over a period of time. But again, the presence of crescentic glomerulonephritis or FSNGN will not tell you that the patient is having a, ANCA-associated vasculitis, or probably it's a vaginous granulomatous. You need to dig it further to tell surely it's a ANCA-associated vasculitis. So that's what I'm going to tell. Whenever you see a focal segmental necrotizing glomerulonephritis, or on the other hand, if you see a crescentic glomerulonephritis, in reality, if they ask you what is the next step that you're going to do, of course, I'll do immunofluorescence as the next step. If immunofluorescence is positive, then there are two possibilities. Then I have to see the pattern of immunofluorescence in this particular setting. If you see the pattern of immunofluorescence, suppose if my pattern is more granular, clumpy, chunky deposits, so it's likely to be immune complex related RPGN. So if my pattern is more linear, more smooth, in this, be thinking about a Goodpasture syndrome. That's the usual possibility in exam. Suppose if immunofluorescence is negative, I'm not seeing any immune complex deposits at all, then this is what we typically refer to something called a post-immune variety. We have studied because there are no immune complexes, because immunofluorescence is negative. And if this is the case, then I'm going to think about a ANCA-related vasculitis, ANCA-associated vasculitis causing glomerulonephritis. So this is the idea. There are many possibilities here. So, I mean, based on the further clinical category. So when I know it's an ANCA-associated vasculitis, now I have to see clinical categorization, which means what is the primary organs that are affected, what is the natural history of the patient, and I have to look at what is the type of ANCA that is seen in the patient. And of course, other areas I have to do a biopsy and I have to find out what is the real problem that is happening in the patient. So I can just tell it's an ANCA-associated vasculitis, but I cannot really tell that what is the exact disease that is happening in the patient. So that's very difficult to tell. So fine. So this is how I'm going to really evaluate a FSNGN or a crescentic glomerulonephritis. If they ask you what is the next step, if you see a crescent, always it is an immunofluorescence. But nevertheless, whenever you see this crescentic or focal segment necrotizing glomerulonephritis, it always indicates a very severe disease. Very, very severe disease. And you have to immediately institute high-level immunosuppression like cyclophosphamide or rituximab. Some high-level immunosuppression is mandatory in this setting. Clear. Now, I told you three characteristic organ involvement in the setting of vaginous granulomatosis, that is ENT involvement, lung involvement, and kidney involvement. Based on that, I can give two types of disease. One is called a localized disease, and second is called a systemic disease. We have E, L, and K involvement is there. Suppose if your ENT and lung involvement is only there, or ENT plus or minus lung, or lung plus or minus ENT, if any one of them or both are there, we'll call it only as a localized GPA. Whenever you get a kidney involvement, apart from this, you can have an associated ENT or a lung involvement, doesn't matter. Whenever there is a kidney involvement, it is called as a systemic GPA. I mean, based on that only you're going to treat, because localized GPA does not need any high-level immunosuppression, but systemic GPA definitely needs high-level immunosuppression for sure. Clear? Localized GPA usually does not need any high-level immunosuppression. Oral steroids alone will be more than enough. But as far as systemic GPA is concerned, you need a high-level immunosuppression like cyclophosphamide rituximab. So kidney involvement is the one that defines that the patient is having a systemic GPA or a localized GPA. Fine. So apart from that, you have other organ involvements also, which is very important to find out. So what are the other organ involvements that you can find in vaginous granulomatosis? Of course, the patients may have ocular involvement. I was telling in the beginning itself, but I withdrew, isn't it? I'll tell later because it needs separate discussion. Ocular involvement can be there in vaginous granulomatosis, where they can get the features like episcleritis, classic rheumatological features, scleritis, episcleritis. Then you can get uveitis, which can be anterior as well as posterior. And you can get granulomas in the orbit. These are called as orbital granulomas. Granulomas in the orbit. These granulomas in the orbit can result in the development of something called orbital pseudotumors. Why I'm writing that point separately? Because that's a question in the exam. Development of orbital pseudotumors in vaginous is something very important to know. And apart from that, you can get neurological involvement as well. As far as neurological involvement is concerned, you will get the characteristic mononeuritis multiplex. We know mononeuritis multiplex. Or you can get peripheral neuropathies, which can involve the cranial nerve, or it can have peripheral nerves also. Mononeuritis multiplex. Clear? Or you can have an isolated cranial neuropathy or a peripheral neuropathy, like isolated median nerve palsy. Even that is possible, or isolated facial nerve palsy. But they are very rare. But mononeuritis multiplex is classical in exam. When they give mononeuritis multiplex, it means it's some form of vasculitis. Depending on the picture, you can tell whether it's a small vessel or a medium vessel vasculitis. PAN also can produce mononeuritis multiplex, as I told you. Skin involvement can happen in vaginous granulomatosis. As I told you before, skin involvement is not specific for any particular vasculitis. In large vessel, you don't get skin involvement, but in small vessel and medium vessel vasculitis, skin involvement is extremely common. So they can produce livedo reticularis like medium vessel vasculitis, or they can produce palpable purpura also. We have discussed this already in the initial table itself. Then they can have hematological involvement. Like for example, these patients have an increased risk of thrombosis, especially increased risk of DVT and pulmonary embolism, especially during active disease. They have high risk of developing deep vein thrombosis and pulmonary embolism. Fine. So these are the other features. But nevertheless, remember what are the things that are relatively uncommon in the setting of vaginous granulomatosis. One is the GAT involvement, which is not very common in the setting of vaginous granulomatosis, and second is the cardiac involvement, which is not very common in the setting of vaginous granulomatosis. Remember, these GAT involvement and cardiac involvement is actually common in Chooks-Strauss syndrome. In fact, in Chooks-Strauss syndrome, the most common cause of death is cardiac involvement only. Myocarditis, heart failure. This will be the usual cause of death in Chooks-Strauss syndrome. But in vaginous, GAT involvement and cardiac involvement is not that common. On the other hand, if they ask you the most common cause of death in vaginous granulomatosis, you will answer typically it's a pulmonary renal syndrome, PRS. Pulmonary renal syndrome is the usual cause of death in patients with vaginous granulomatosis, which means it will not the lung and the kidneys both. That is the usual reason for death. So which means pulmonary renal syndrome once again does not mean it's vaginous. You have a differential diagnosis for pulmonary renal syndrome where many other conditions can produce. First, you have infectious causes. You have to rule out infections. Infectious cause of PRS are there. Like for example, in our country, leptospirosis is so common. Hantavirus can cause this. So many infectious causes are there. Then you have immunological causes of pulmonary renal syndrome. In that, you can have CT-related causes. Like for example, you have SLE, which can cause pulmonary renal syndrome. We know that. So here in immunological causes, you know the antibodies will be positive. For example, ANA positivity will be there strongly, you know. Vasculitis can produce pulmonary renal syndrome. If vasculitis is causing pulmonary renal syndrome, typically it is very commonly an ANCA-associated antibody only. So that is the one that is typically going to cause pulmonary renal syndrome. Suppose if it's going to be vasculitis, I always think about an ANCA-associated vasculitis. That's what I'm going to think about. Or it could be a Goodpasture syndrome. Or very rarely it could be a cryoglobulinemia. But in exam, usually it means a ANCA-associated vasculitis or a Goodpasture syndrome. So in this setting, see what is the type of ANCA that you're seeing. See ANCA. If ANCA is positive or ANCA is negative. If ANCA is positive, then I'm dealing with the ANCA-associated vasculitis. In this setting, see what is the ANCA that you're seeing. Whether it's a C ANCA or whether it's a P ANCA. If it's C ANCA, usually it goes towards vaginous granulomatosis, and these patients will not have eosinophilia, and they'll have a prominent ENT involvement, which clearly tells you that it's a vaginous granulomatosis. Suppose if it's a P ANCA that you're seeing, then in this setting, there are two possibilities. Either it could be a microscopic polyangiitis, which can very commonly cause pulmonary renal syndrome, or it could be a Chooks-Strauss syndrome, which rarely causes pulmonary renal syndrome. I mean, rare in the sense I'm talking about a pulmonary renal syndrome is rare in Chooks-Strauss syndrome compared to vaginous and microscopic polyangiitis. So microscopic polyangiitis, characteristically in exam, they will give a clue. There will be no eosinophilia. Similarly, there will be no prominent ENT involvement, and clearly they will tell there is no granulomas. That's very characteristic of microscopic polyangiitis. Whereas vaginous granulomatosis and Chooks-Strauss syndrome, in biopsy, you will get granulomas. They are granulomatous inflammation. Chooks-Strauss syndrome, and all the infiltrates in the body will be made of eosinophils. And so based on this only, you are going to tell which is the type of pulmonary renal syndrome that you are basically seeing in this patient. And if ANCA is negative, usually it goes towards a Goodpasture syndrome. Usually it goes towards a Goodpasture syndrome. So that is how you approach an exam. So this is the way to approach your pulmonary renal syndrome in exam. Or you can approach through renal biopsy also, as I told you. So whenever the patient is having pulmonary renal syndrome, alternative way of approach is to do a renal biopsy and find out. In the renal biopsy, whenever you have a pulmonary renal syndrome, very commonly they will give this kind of crescentic glomerulonephritis. Whenever you see crescentic glomerulonephritis, if immunofluorescence is negative or immunofluorescence is positive, based on that also you can divide. So Goodpasture syndrome and other ANCA-associated vasculitis can be identified through this kind of renal biopsy also. Or if there is no renal biopsy, then you can approach through this simplified algorithm also. In exam, this will be very, very effective and very, very useful. But remember, most important point to notice that pulmonary renal syndrome does not mean it's only vaginous granulomatosis. Many students falsely believe that pulmonary renal syndrome means it is vaginous granulomatosis. In fact, in countries like India, where leptospirosis is so florid, you have to think about those causes that causes pulmonary renal syndrome. And you know, leptospirosis is going to have other manifestations of its own as well. Now, how will you diagnose vaginous granulomatosis? So vaginous granulomatosis in exam, as a topology, it's very easy to diagnose. You'll get a characteristic triad in exam. You get sinusitis, you get hemoptysis, and they'll give a renal failure, AK. Very typical. This is how they expect you to diagnose, and they will ask you what is the next step you will do. You will tell it's a C-ANCA. This is a typical way you get an exam question, but you know now, vaginous granuloma is something beyond that. It's not like that just typical triad that you get in exam. Already, I will suggest more than this kind of triad that you see, more often go for a ENT, lung, and a kidney involvement. It could be anything in the ENT, like subglottic stenosis. It could be anything in the lung, ranging from cough to hemoptysis. It could be anything in the kidney, ranging from AK to a crescent formation. So look for this particular kind of a triad in reality. And in that, if the C-ANCA is positive, it strongly denotes that the patient is having a vaginous granulomatosis. So that's what it means. But remember, even though C-ANCA can suggest that the patient is having a vaginous granulomatosis, but it cannot confirm that the patient is having vaginous granulomatosis or not. So of course, you need to do a biopsy. In biopsy, you will see a very characteristic finding. You will see small vessels. Like in the idea of the biopsy is to see the small vessels. If you see a small vessel like this small vessels will be loaded with inflammatory infiltrate, which means the walls of the vessels will be having inflammatory, and surrounding also will have some inflammatory spilling will be there. The walls will be loaded with inflammatory infiltrate, and it will be highly concentrated. And usually they'll be made of neutrophils. And this is not the only finding, but nearby you will be seeing a granuloma. Nearby you will be seeing a granuloma. If you see this non-eosinophilic infiltrate on the vessel wall, which means a non-eosinophilic vasculitis that is happening, along with it, if you see a nearby granuloma, it's a granulomatous non-eosinophilic vasculitis, then it confirms that the patient is having a vaginous granulomatosis. With the characteristic clinical picture, now you can easily pick up that this patient is having a vaginous granulomatosis. And it's a necrotizing inflammation. It's not even a odd inflammation. There will be a vessel wall necrosis will be there, exudation of blood will be there. And that all you will be seeing in typical pathology description. But this is what I need. Nearby granuloma with the neutrophilic, and more than neutrophilic, I will tell it's a non-eosinophilic infiltration of the small vessels. So that is typical of a vaginous granuloma, and this is how you diagnose a vaginous granuloma. It will be necrotizing in nature as well. Now, go to the treatment. As far as the treatment is concerned, so simplified treatment approach is localized disease. I can use oral steroids alone. That must be usually enough for localized disease. Maybe to low dose to high dose, whatever you want to try. But for systemic GPA, you need a high level immunosuppression. For example, whenever the kidney is involved, RPGN is there. Definitely we know that we need to start with pulse methylprednisolone, 1 gram methylprednisolone for 3 days, IV. Pulse IV methylprednisolone, plus I'll be using either a cyclophosphamide or probably I can use even a rituximab. But in our center, we typically prefer rituximab. We don't really prefer cyclophosphamide because of the high level of side effects with cyclophosphamide. Rituximab is naturally expected because rituximab reduces the antibodies and that clears off the anti-neutrophil cytoplasmic antibodies, even if it is at undetectable level. So definitely that should help. Cyclophosphamide also helps in a great extent. But the problem is this limiting side effects. We know it has hemorrhagic cystitis as the side effect, but even though that is told as the first, but can be easily prevented by giving Mesna prophylaxis because of the molecule that is formed in as a metabolite that is formed with cyclophosphamide that is called acrolein. And apart from that, they can result in bone marrow suppression, causing severe cytopenias. They can produce mucositis. They can produce GI side effects like diarrhea and vomiting. Apart from that, they can produce gonadal toxicity. And that's where I'm concerned with, because if I'm giving to a young patient who has not completed family, this becomes a serious issue. There is 20% chance that cyclophosphamide can fry out your gonads. So gonadal toxicity is a very important problem with cyclophosphamide. And apart from that, I have an increased risk of future bladder cancer. One of the important risk factors for getting bladder cancer in the future is usage of cyclophosphamide in the past. And I also have increased risk of future MDS and AML, myelodysplastic syndrome and acute myeloid leukemia. Remember, usually this MDS and AML that happens in the setting of prior alkylating agent use. That is one of the examples of alkylating agent is cyclophosphamide. Prior alkylating agent uses, they have a very worst cytogenetics. versus cytogenetic, which means they are going to have a very poor prognosis. They will die usually. They will not survive. So many side effects with cyclophosphamide. So that's why currently costly alternative, but still it's better. They'll prefer rituximab. That's a better option. But they will ask you what are the indications for plasma exchange in vasculitis. It's the same as that of SLE. Only two indications as far as vasculitis is concerned. One is going to be diffuse alveolar hemorrhage, and second is going to be your RPGN, that is crescentic glomerulonephritis. So these are the only two indications as far as the plasma exchange indications is concerned. That's all. Okay. I think Wegener's granulomatosis is over. So do you understand Wegener? So that we'll move on to next one, that is Chooks-Strauss syndrome. Clear? Okay. The next thing, what we are going to move is towards the EGPA. EGPA is eosinophilic granulomatosis with polyangiitis, that is Chooks-Strauss syndrome. Pranay is asking indications for plasma exchange, only two, diffuse alveolar hemorrhage and RPGN. That's all. Or crescentic glomerulonephritis for that matter. You can ask in any way. That is Chooks-Strauss syndrome. Basically, Chooks-Strauss syndrome is divided into three. Three phases basically. It's going to be eosinophilic inflammation, but we need to have this kind of three distinct features will be there. These three distinct clinical classification will be there, where they can pass from one stage to another phase. The first one we typically called as a prodromal phase, and second one we called as a eosinophilic phase. Eosinophilic phase, and third one we called as a vasculitic phase. This is the time where they will produce life-threatening vasculitis. Life-threatening vasculitic phase. The prodromal phase usually takes place for approximately around 2 to 7 years in general. It can vary, but still usually it is around 2 to 7 years. So where the patients will be developing bronchial asthma, and that's the most common picture to start with. Bronchial asthma is going to be the most common. And if they ask you like in Wegener's, in Chooks-Strauss, what will be the most common finding, most common presentation? That's going to be asthma. Sinusitis, though, can happen in Chooks-Strauss syndrome also, but asthma is going to be the most important, the classical description in any clinical description of Chooks-Strauss syndrome. How will you differentiate? Because it can be a childhood asthma also. How will you differentiate? Usually this asthma will be of adult onset most of the times, and it will be refractory to your treatment, which means most of the patients will be requiring oral steroids to control the asthma. They can become refractory over a period of time. And third thing that you should think about this asthma to be not of this thing is the usual child asthma is no history of atopy. Patient will not have any history of background atopy, and the patient will not have any family history as well. So these sort of asthmas usually should give you a suspicion that this could be something else. It's not a routine asthma that you're getting. So adult onset, that's the most important point. Refractory, no history of atopy, background atopy, or no family history is there. So whenever asthma is not responding to your treatment and asthma becomes refractory, there are few differential diagnoses. The first differential diagnosis, of course, non-compliance or poor inhaler use technique. So that should be the usual cause. Apart from that, it could be allergic bronchopulmonary aspergillosis, or it could be continuous exposure to allergens where the patient is not getting any idea what the allergen is, so that they're getting continuously exposed, so that getting asthma attacks again and again. Or they can be using some drugs like beta blockers or aspirin. Finally, last but not the least, you think about Chooks-Strauss syndrome. There are many differential diagnoses for uncontrolled or a refractory bronchial asthma. One of the DDs is Chooks-Strauss syndrome. Fine. At the same time, these patients can have other allergic manifestations. Like, for example, they can get sinusitis also, which means sinusitis is not like it will be seen only in Wegener's granulomatosis. It can be seen in Chooks-Strauss syndrome as well. And they can develop nasal polyps, and they can develop, other issues also. Like, everything is allergy sort of a thing. In Wegener's, you got necrotizing sort of a thing. Here, it will be more of a allergic manifestation, but without an allergen. That is because eosinophils are behaving very bizarrely here. And in the eosinophilic phase, there will be a blood and tissue eosinophilia. That's the most important finding. There will be blood eosinophilia. Because of that, these eosinophils will start infiltrating the tissues as well. There will be blood and tissue eosinophilia. During this situation, the asthma worsens more, which means they'll become completely refractory. You need continuous steroid exposure to treat this asthma. So I can write here, it becomes steroid dependent type, where the patient should take steroids to control the asthma. Otherwise, it will not be controlled with usual inhalers and all. So later on, they'll go for something like a Loeffler syndrome kind of a presentation, where there'll be tissue infiltration in a lot of areas. Like for example, even in chest X-ray, you will get infiltrates. That is due to tissue infiltration by the eosinophils. And then you go for the vasculitic phase. This is the point where organ involvement will start because of infiltration by the eosinophils. This usually happens after 5 to 7 years of the initial asthma. So during the organ involvement, typically the asthma improves during this setting, because you can understand that these eosinophils are now busy in destroying the organs rather than causing asthma. So the asthma generally improves by this time. But apart from that, you can get a variety of organ involvement. Like for example, the G8 involvement can happen in this setting. So G8 involvement means they are going to produce typical eosinophilic gastroenteritis, which can manifest as a bloody diarrhea. Abdominal pain, bloody diarrhea can happen during this phase. And apart from that, they can have neurological involvement, and the classic neurological involvement is going to be your mononeuritis multiplex. Very classic in exam. More than vaginous, mononeuritis multiplex in exam goes towards a Chokes-Strauss syndrome only. Apart from that, they can result in cardiac involvement. Cardiac involvement can result in the development of myocarditis. They can also cause coronary vasculitis. But they involve the small vessels. More than I'm asking about vasculitis, you can talk about arteritis, the small vessels, the penetrating vessels. That will be the one that will be affected. Because of that, they can go for MI. Because of these two, they can even go for subsequent heart failure, which is possible. So remember, as far as Chokes-Strauss syndrome is concerned, this cardiac involvement is the most common cause of death in these individuals. In vaginous, it's the pulmonary renal syndrome, and Chokes-Strauss syndrome is the cardiac cause. That's going to be the most common cause of death. They can have renal involvement also, in the sense they can develop glomerulonephritis, which can be the FSNGN type, even though renal involvement is a little rare compared to vaginous. I'm writing only compared with vaginous. Compared with vaginous, it's a little less common. And they can have skin involvement. Typically, they can produce that palpable purpura as well. Palpable purpura, livedo reticularis. All these things are possible in patients with Chokes-Strauss syndrome as well. Fine. So now you'll be knowing. So what are the features of Chokes-Strauss syndrome? But in exam, it will be a very simple triad. So usually in exam, they'll be giving a triad of asthma. They'll give eosinophilia. And they'll be giving either a mononeuritis multiplex, or they'll be giving a myocarditis, heart failure kind of a picture. So if you see this kind of a triad, usually in exam, you go towards a Chokes-Strauss syndrome. That's all. But remember, this kind of triad can be seen in many other conditions. For example, if mononeuritis multiplex is there, then I can be sure it's a vasculitis along with eosinophilia and asthma. Now you can concretely establish the diagnosis of Chokes-Strauss syndrome. That's why this is the commonest triad you get in exam. But if I give myocarditis, then that situation becomes a little difficult, because there are other hypereosinophilic syndromes which can still cause myocarditis and heart failure. So in that situation, you need to have the help of other investigations like ANCA and all. So that will be seeing subsequently. So as far as the diagnosis is concerned, investigations are concerned, the most important finding is eosinophilia. It will be moderate to severe most of the times. That's a very important finding and a necessary finding to diagnose Chokes-Strauss syndrome. Usually it will be very high. Eosinophils will be elevated in the range of 5,000 to 10,000 per microliter. Microliter means usually the normal eosinophil count is less than 500. If it is more than 500, it is eosinophilia. Isn't it? 500 to 1,000 means mild, 1,000 to 1,500 means moderate, more than 1,500 means severe. In this patient, there will be a severe eosinophilia. Usually in the range of 5,000 to 10,000. That will be the eosinophil count. Severe peripheral eosinophilia will be there. And most of the patients will be having P-ANCA positive, at least in exams. And this antibody what we're dealing with is anti-MPO antibody, we know that. And please understand, in reality, P-ANCA is positive only in 40% of the cases. Remaining 60%, few may have probably a C-ANCA positive, but very few. But majority of them can be ANCA negatives as well. So that's not a very confirmatory investigation. In exam, typically you will get a P-ANCA, anti-MPO antibody, if they wanted to diagnose a Chooks-Strauss syndrome. But we know the gold standard is going to be the biopsy only. Biopsy, where you take is a big question. Either you can take from this neurological involvement. If the patient is having neurological involvement, you can take from the sural nerve. You can take biopsy from that area. Or you can take from the GIT. If you have that erosions, ulcers because of eosinophilic gastritis, you can take from those areas. Or you can take biopsies from the skin, where you're going to have this kind of pallor. That can also show some changes. But renal is a very poor site, because in kidney you will see that FSNGN or crescentic glomerulonephritis. Based on that, you can diagnose it's an ANCA-associated vasculitis, but you cannot clearly tell it's a Chooks-Strauss syndrome for sure, unless and until there is a significant eosinophilic infiltrate. So as far as the biopsy is concerned, the biopsy is very typical. You will have a vessel that is surrounded by definite inflammation. So let me talk about here in a different color, because these are eosinophilic infiltrates, not like neutrophils. So you will have eosinophilic infiltration of small vessels like arterioles, capillaries, venules. This will be usually having a eosinophilic infiltrate. And that alone is not enough. You should have a nearby granuloma, as I told you. So it tells you it's a granulomatous necrotizing eosinophilic vasculitis, and that will tell you that it is a Chooks-Strauss syndrome. So because it's a granulomatous condition, the proving of the granulomas is very, very important. Without granulomas, it's very difficult to tell the patient is having a Chooks-Strauss syndrome. So that should be a granuloma. So this is a typical finding, and there will be associated fibrinous necrosis, which is common in any vasculitis. So that will not tell you any differential diagnosis. When you want to know the treatment of Chooks-Strauss syndrome, treatment is typically based on something called FFS. FFS means 5-factor score. So already I think I've told you FFS. So serum creatinine more than 1.6. If the patient is having proteinuria more than 1 gram per day, and if the patient is having CNS involvement or cardiac involvement or a GIT involvement. So each is given 1 point. So total score is, 5. Minimum score is 0. So if the score is 0, in this setting, I'll be just treating with the oral steroid. That's enough. If the score is more than or equal to 1, then I have to use high-level immunosuppression, typically in the form of either pulse methylprednisolone plus cyclophosphamide, or even I can use a rituximab instead of cyclophosphamide in that setting. So 0 means just oral steroid is enough, but treatment is totally based on something called a 5-factor score. That's all. This is how I'm going to arrange the treatment, which means what is the idea of 5-factor score is if there is any organ involvement or significant organ involvement, you have to give a high dose immunosuppression. If there is no organ involvement, the patient is having only asthma and kind of minor manifestation, then oral steroids alone will be more than enough in this situation. So, but remember, the most common cause of death in Chooks-Strauss syndrome is not pulmonary renal syndrome. Actually, it is cardiac involvement. That is myocarditis, MI, heart failure. So this will be the usual reason for death in Chooks-Strauss syndrome. And again, it's having a multi-organ involvement. And remember, this GIT involvement that is happening in the phase 3. Don't get confused, because if you study Harrison, they would have clearly given GIT involvement can happen in the eosinophilic phase itself. So which means this phase also you might get a tissue eosinophilia. So it's not only the lung that can get infiltrated during this area, even GIT can have infiltrates in this area causing eosinophilic gastritis, which means eosinophilic gastritis is like a common thing. So it can happen during this phase, or it can happen during the last stage of the disease also. So that's a sort of a overlap there. But nevertheless, you know what is the idea and how to diagnose a Chooks-Strauss syndrome in exam. But don't diagnose Chooks-Strauss syndrome without eosinophilia. And one more drug, if you are clever, you can use in Chooks-Strauss syndrome is mepolizumab. Mepolizumab has been approved in Chooks-Strauss syndrome. I already told you when I was discussing about the monoclonal antibodies. Because this is an anti-interleukin 5 antibody, because it's an anti-IL-5, they reduce the eosinophil proliferation and growth. So that's why, because Chooks-Strauss syndrome is basically an eosinophilic condition, you can use mepolizumab also, which is actually approved for treatment for refractory case of Chooks-Strauss syndrome. Previously, there was a popular belief that Chuksta syndrome can be triggered by your Montelukast and your Zafir-Lukast. These are, what are Montelukast and what are Zafir-Lukast? What are these? Where they act? What is the site of action? No, they are not mast cell stabilizers. They are leukotriene receptor antagonists. Correct. They are leukotriene receptor antagonists, and previously thought that this leukotriene receptor antagonist can trigger the development of Chuksta syndrome. That's what has been originally believed, but later on many studies have proven that many of these patients with refractory asthma, because of Chuksta syndrome, are getting leukotriene receptor antagonists, and over a period of time they evolve into Chuksta syndrome phenotype. So because the disease has a subacute to chronic course. So that's why it's been believed that these leukotriene receptor antagonists are not the cause, but because it's used in majority of the Chuksta syndrome patients, without knowing that they are Chukstas, later on we believe that they are the ones as a cause of Chuksta syndrome. No, they are not. They don't trigger. And currently it's been cleared. You can use Montelukast and other leukotriene receptor antagonists without any much problem. Okay, all right. We have completed EGPA. Now we need to know about this microscopic polyangiitis, isn't it? So how we are going to tell about this microscopic polyangiitis? Because you need to differentiate with another disease called Polyarteritis nodosa. But whenever you talk about a microscopic polyangiitis, it's a disease that is extremely similar to vaginous granulomatosis, but there are two exceptions. One, ENT involvement will not be there, and second is your granulomas will not be there in biopsy. These are the two exceptions, but apart from that, you can imagine microscopic polyangiitis as extremely similar to that of your Chuksta syndrome. But in exam, more importantly, you need to differentiate microscopic polyangiitis with Polyarteritis nodosa. That's how they want to differentiate. So why the difference is there always? Because originally, the Polyarteritis nodosa that we talk about right now, the PAN, it's often called as a classic PAN. This is an old name, old terminology. And microscopic polyangiitis in those days, old terminology said that this is a microscopic PAN, or otherwise referred as a micropan. So why they tend to call both these diseases as Polyarteritis nodosa? And why currently they have been separated? Because both these disorders does not produce granulomas in biopsy. They do not produce granulomas. Both these disorders will not have granulomas. That is why, both these disorders have been confused a lot in the beginning. They thought that there was a medium vessel involvement in the form of classic PAN, and the same disease involves the small vessels called as microscopic PAN. Because in histology, both these disorders characteristically did not have any granulomas. But later on, after the discussion about the ANCA and all this stuff, we believe now that both are completely different disorders and they don't have any relationship with each other. So that's why we need to know the difference between these two. First of all, PAN is basically a medium vessel vasculitis, whereas microscopic polyangiitis is basically a small vessel vasculitis. That's the first thing that you need to know. And apart from that, PAN, I told you, 10% of the patients will be hepatitis B virus positive. Even there are rare association with HCV also. But in exam, don't tell this. In exam, always tell PAN means hepatitis B positive. One of the important extrahepatic manifestations of hepatitis B virus is Polyarteritis nodosa. And the incidence of HBV-related PAN has come down dramatically nowadays thanks to the vaccination that we are doing. Previously, it was 30-40% when I was studying in my undergraduation. Now it has come down to 10%, 5 to 10% almost. So as far as the microscopic polyangiitis is concerned, there is no such association. HBV does not cause this microscopic PAN. So that's another important difference. That's why the disease has been separated into two different categories. Of course, this is ANCA negative, and this is typically P-ANCA positive. Not always. 60% of the cases will be P-ANCA positive. 60 to 70%, they'll be P-ANCA positive. That's another important difference. And the only common thing is in biopsy, they don't show granulomas. Both will not produce typical granulomas. And apart from that, majority of the symptoms will be overlapping with each other, but except few things. Like for example, if you take the pulmonary involvement. Pulmonary involvement is never a feature of Polyarteritis nodosa, but it's extremely common in the setting of a microscopic polyangiitis, like infiltrates, hemoptysis, diffuse cellular hemorrhage, pulmonary renal syndrome. All these things are very characteristic of microscopic polyangiitis, but pulmonary involvement is extremely rare with Polyarteritis nodosa, which means pulmonary renal syndrome is impossible in the setting of PAN, pulmonary renal syndrome is very classical of a microscopic pollen. So in exam, if you get a pulmonary renal syndrome, you can rule out PAN. So pulmonary involvement is not possible in PAN. Then renal involvement can happen in both these conditions. But if you want to differentiate, it's very easy to differentiate because renal involvement in PAN will be more of a infarct because of the aneurysms they produce. These infarcts will result in hypertension as well as hematuria because they involve this second order or third order divisions of the renal vessel. So they'll cause this microaneurysms. Because of that, they'll produce hypertension and hematuria. But typically in exam, there will be a clue that this hematuria will not have RBC cause, telling it's not of glomerular origin. But in this setting, we know you're going to result in development of glomerulonephritis here. Because they produce glomerulonephritis, there will be a characteristic hypertension, hematuria, but there will be RBC cause here. They can have hypertension. Hypertension is a common feature of glomerulonephritis. Apart from that, if you do angiography, characteristically they will have microaneurysms. Microaneurysms, where microaneurysms typically in the renal vasculature and in the GIT, that is mesenteric vasculature. That's very classic of a polyarteritis nodosa, microaneurysms. Here, angiography will be completely normal. So you don't develop any problems because it's a small vessel vasculitis. From the beginning, I'm telling small vessel vasculitis will not have any angiography. We not have any changes in the angiography. And yes, of course. So these are going to the major difference. And GIT involvement and skin involvement, neuro involvement can be common between them. So GIT involvement can be there in both. Skin involvement can be there in both. Neurological involvement can be there in both. So these things will not be able to differentiate. It's always about the type of renal involvement. That will be a clue in exam. And it will be this microaneurysms that will be a clue in exam. Or the hepatitis B virus that will be a clue in exam. Or probably this ANCA that will be a clue in exam. So this is how we are going to differentiate. Treatment of both these disorders is practically based on something called FFS. That's called a 5-factor score. We know how to treat based on the 5-factor score. I've already told you. Same thing you're going to use here also. And remember, diffuse salivary hemorrhage can happen in microscopic polyangiitis also. So for example, pulmonary involvement in the sense I'm talking about infiltrates, diffuse salivary hemorrhage, TH, hemoptysis. So all these things can happen in the setting of microscopic polyangiitis, which is very, very uncommon in the setting of a polyarteritis nodosa, classic PAN. So now, what I was about to tell. Okay. Now let us see the images before that. So I think I forgot what I want to tell. So this is a classic example of a vaginous granulomatosis. So where you can see this kind of multiple nodular structures in the lower lobes. These are nodules that are in the lower lobes, and you can see these are thick-walled cavities basically. You can see some nodule have not cavitated. This nodule has clearly cavitated. This is an example of a cavity. So this is vaginous granulomatosis, typical nodules. And this is an example of an FSNGN. That's a focal segmental necrotizing glomerulonephritis. And if you see here, this is the typical crescent. A crescent is formed due to parietal epithelial cell proliferation, isn't it? Parietal epithelial cell proliferation along with some fibrin deposition on the way will result in the typical formation of a crescent like this. This is a crescentic glomerulonephritis. And this is an example of an RBC cast, which is typical of a glomerulonephritis. And this is a immunofluorescence, where immunofluorescence typically you will not have any finding. It's looking dark. There's no much green staining over here. So this is a post-immune variety. So all these are favoring ANCA-associated vasculitis. It will not tell you the special type of vasculitis, but these are ANCA-associated vasculitis. This is an area of necrosis. This is a focal segmental necrotizing glomerulonephritis. That's also suggestive of ANCA-associated vasculitis only. But on the other hand, if you compare that with our original disease, that is SLE, in SLE, this is, not only in SLE, in any immune complex vasculitis, this is how you get. If it's an immune complex vasculitis that is involving the glomerulus, producing RPGN, this is how it will look like. See how much immunofluorescence you are seeing. These are chunky, like granular deposits that are seen in multiple areas. Details is not needed for your level, but at least you can see there are chunky deposits that are located. This is typical of immune complex vasculitis or any immune complex related glomerulonephritis or any immune complex related glomerulonephritis causing RPGN. This is how it looks like. So, but if you see vaginous, it's not looking like that at all. So that itself will tell you that this patient is having a post-human variety only. And I think we need to see the pan also. Polydys nodosa finding. So this is a typical pan finding. So if you see in the angiogram, this area is not visible at all. So this is actually an infarct, renal infarct. That is because of polydys nodosa. And if you see this second order, third order branches are showing this kind of microaneurysms. So these are small aneurysms that you see in the renal vasculature suggestive of polydys nodosa. And this also kind of microaneurysm that you get in the mesenteric vasculature. So this is the superior mesenteric and inferior mesenteric vasculature. Again, the second, third order vessels from the mesenteric vasculature is showing this kind of small aneurysms. You can see one more here. So this is a microaneurysm again. And typically, PAN will cause something called myositis. I didn't tell that, but PAN will cause something called myositis and testicular involvement. Because PAN can produce myositis, sometimes muscle biopsy can help you. Muscle biopsy shows that there is a vessel around which there is a serious inflammation going on. These blue structures are there. And this kind of, around the vessel, if you see this kind of onion skin kind of a pattern, minimal onion skin kind of a pattern, that always indicates a fibrinoid necrosis. So this is a medium vessel in the muscle that is going for fibrinoid necrosis, surrounded by a lot of inflammation. And you can also see that this is a myositis. So these muscles are also infiltrated with a lot of inflammatory infiltrate, which is typical in polydys nodosa. Polydys nodosa can produce myositis as well. So these are typical images with regards to polydys nodosa in this setting. And so what are the other pointers, other key pointers apart from your routine points that I've told you for polydys nodosa? That is a testicular involvement. So whenever you have a testicular pain along with a vasculitis, this is characteristic. It's like a no-brainer. So testicular involvement in a vasculitis is equal to PAN. A vasculitis picture plus patient is having testicular pain, close your eyes and click on PAN. That's all. It's a polydys nodosa. That's all. There's no other diagnosis possible in the exam, because that's very characteristic and so characteristic of polydys nodosa. That's all. I think this must settle the debate. That's all. So this is the difference between microscopic polyangiitis and polydys nodosa in reality. Clear? That's all. Do you understand how to differentiate in exam? So this must be more than enough. This the differential diagnosis going to be the most important. So that we can move on to the other parts of small vessel vasculitis, if you understand, like immune complex vasculitis. Okay, shall we move on? Okay. So let us move on to the immune complex vasculitis, which is going to be the last form of vasculitis, small vessel vasculitis. That is immune complex vasculitis. Goodpasture syndrome is very easy to find out, because in exam, Goodpasture syndrome will come with the pulmonary renal syndrome. Again, typically, how to diagnose Goodpasture syndrome? There will be a pulmonary renal syndrome. They'll come with hemoptysis, diffuse cellular hemorrhage, RPGN. When you take a biopsy, they'll be positive. They'll be showing that smooth linear deposits. That's what I told you. That whenever you get that kind of line like smooth linear deposit, that always means it's a Goodpasture syndrome only in exam. You will not get a glandular deposit. Immunoglobulins will be positive, but they'll produce this kind of a smooth linear deposit, which I'll show you in nephrology, if possible. Now, we are going to immune complex vasculitis, that is small vessel vasculitis. The first is the IG related, because we have two types, IG and non-IG related. The first one is IG related. IG related vasculitis is what we refer to as Henoch-Schönlein purpura. That is HSP. Remember, this is the most common form of vasculitis in children right now. And remember, typical age group where HSP happens is within 19 years. Even though we have some atypical HSP that happens after 19 years as well, but typically it happens within 19 years of age in adolescents, children, teenage group. So that's where you typically get Henoch-Schönlein purpura. And as far as we know, what is the characteristic triad of HSP is concerned? As so that HSP is concerned, it's going to typically involve the GIT very, very commonly compared to other small vessel other immune complex vasculitis like cryo, where they can have abdominal pain, they can have bleeding, abdominal bleeding in the form of melena, hematochezia, even hemoptysis. So bleeding is possible, abdominal pain is possible, and this abdominal pain typically will be of colicky abdominal pain most of the times. And Even intersusception is possible because we are dealing with the children. Intersusception is possible where they can present with a red currant jelly type of stool as well. So GIT involvement is very typical. So very important again. And second thing that is characteristic is the arthralgia and arthritis they used to get. This arthralgia is again a non-erosive form of arthralgia, and they generally tend to get no deformities, and it's a non-deforming type of arthralgia and arthritis. And most common location is going to be the knee joint. Knee is going to be the most common, even though it can involve the hip, ankles, and all these areas, but typically they'll involve the knee joint. And this will be a polyarthralgia rather than a mono or oligoarthralgia. This will be a polyarthralgia. And large joints is the one that will be typically involved: knee, hip, ankle, and all these places. And lower limbs will be involved more than the upper limb joints. And third most important is the palpable purpura that you get in these patients, which is very classic. Everyone would have been aware of this finding of palpable purpura. And typically palpable purpura will be present in the lower limbs, especially in the extensor surfaces, and can be seen in the buttocks as well. And typically these palpable purpura are due to vasculitis. So the platelet count will be normal, that it's not due to thrombocytopenia. That's a very old question. I don't know why they are still asking that. Platelet count tends to be normal and will be non-blanching in nature. Because it is due to vasculitis, why should they blanch? They won't blanch. And it's not due to just simple vessel dilatation. Plus there can be other features as well. Other features, one of the important other features is the glomerulonephritis that these patients can get. So this glomerulonephritis can be either asymptomatic or they can have a symptomatic glomerulonephritis as well. Most of the time it will be asymptomatic and subclinical only. They won't be having any symptomatic or a fulminant glomerulonephritis. So this glomerulonephritis is due to IgA deposition in the mesangium. IgA deposition in the mesangium. These are due to IgA deposits. And more often, before getting enoxational purpura, most of the children will have a URI prodrome. They will have a sore throat, stuffiness of the nose, and they might have a URI-like kind of a prodrome. And it's more often going to affect male children than female children. And typical age group is going to be around 11, 12 years. That's the usual age group that they will be affected. And male children will be more affected than the female children. And you will get the disease more in winters than summers, during the cold season. And probably that makes you think about a probable viral etiology is also there, but that's possible. But we have not clearly thought about any much viral exposure or even bacterial exposure like streptococcus has been thought, but we don't have any clear-cut connection with them. But nevertheless, most of the patients with enoxational purpura, before getting these problems, they'll be having a characteristic URI prodrome. Okay. There are two disorders. One is IgA nephropathy and HSP. Both are currently considered to be a spectrum of a single disease. IgA nephropathy we'll be seeing in the next section, probably in the glomerulonephritis section, which we'll be discussing in the kidneys. Diagnosis. Diagnosis as such, these patients will not have ANCA. They'll be typically ANCA negative only. So that's a very important point. And diagnosis is going to be much easier with the characteristic clinical presentation. At the same time, they're going to have this palpable purpura, which forms a very easy site for taking a biopsy. So we're going to do a skin biopsy in this setting. Once you take a skin biopsy, what you see in HP is something called a leukocytoclastic vasculitis. That's very characteristic. Leukocytoclastic vasculitis, very characteristic of this immune complex vasculitis. So the presence of leukocytoclastic vasculitis does not tell you it is enoxational purpura. It just tells you it's an immune complex vasculitis that is affecting the skin. So once you see this, now I'll do an immunofluorescence. In immunofluorescence, if I see IgA deposition around the vessels, for example, if you take a small vessel and around this vessel, if I have this kind of IgA deposition, so you have epidermis and dermis. Let us assume this is epidermis, this is dermis. In the epidermis, you will have numerous, in the dermis, you will have numerous vessels. These are small vessels. If characteristic IgA deposition, you can tell what is the type of antibody. So if you have IgA deposition around this dermal small vessels, that confirms that your diagnosis is enoxational purpura. It's easy to diagnose. Literally speaking, it's much easier compared to other vasculitis to diagnose. Just a skin biopsy is more than enough, because this palpable purpura in enoxalan purpura literally happens 100%, which means without that, enoxalan purpura will not come. That makes our diagnosis also much easier. And that proving that IJ deposition is the key. Without immunofluorescence, you cannot tell it is a enoxalan purpura though. And as far as the treatment is concerned, the most important thing to understand is the fact that it's a completely self-limiting disease, which means it will resolve within 1 to 2 months usually. So it's going to be a completely self-limiting disease. And more often, if you want to have a treatment, then you can treat with some, like basic drugs like NSAIDs plus or minus steroids. You need higher level immunosuppression only for one reason: if there is a significant renal involvement. The glomerulonephritis is severe, causing a picture like that of an RPGN. Sometimes you can get RPGN with HSP, because if there is significant immune complex deposition, that can progress towards crescent formation RPGN. RPGN is just a severe form of glomerulonephritis. That's all. Or you can, if you have a severe GAT involvement causing severe bleeding and all this stuff, severe enteritis, then in that setting you can give high level of immunosuppression. But apart from that, most of the time you don't need any much treatment. You just need some NSAIDs plus steroids. So steroids are the mainstay basically. You give a short course of steroids, that itself will be enough for the child to recover. They'll have a good recovery, and the prognosis very good in this situation. Then we have other types of immune complex vasculitis. The next one we need to know is a hypocomplementemic urticarial vasculitis. That is HUV. Remember, this is a non-IgA type of vasculitis. Typically, the patient will come with a vasculitic urticaria. So how will you differentiate a vasculitic urticaria from a usual routine urticaria? There are 2 points are there. So one, vasculitic urticaria will be very prolonged, more than 24 hours, whereas the usual allergic kind of an urticaria will not be this prolonged, and usually it will settle within a probable period of like maybe 6 to 12 hours usually. If it's an allergic kind of acid, once the allergen is removed, it will settle. So it will be for less than 24 hours. It's going to be more than 24 hours. And allergic kind of urticaria will be more often, it will be kind of itchy type. So here there will be no pruritus, but you'll get a typical urticaria. That's how they're going to present. So vascular kind of an urticaria. And one important point to note for exams is they can have one antibody that is associated with this called as anti-C1q antibody, even though this is non-specific for HUV. But still, it can be seen in other disorders like HIV, SLE also. You can see anti-C1q antibody. We have discussed yesterday. So, but still, this antibody has been thought to play a very important role in the setting of hypocomplementary urticarial vasculitis. And patients may have pulmonary involvement. Especially they can present with like a sort of an obstructive lung disease like picture. So that can also be a clue in exam to diagnose a hypocomplementary urticarial vasculitis. The gold standard, of course, is going to be the biopsy. So where again you can see this kind of leukocytoclastic vasculitis. I'm going to write as LCV. If you do a immunofluorescence, it will be still positive, and they'll be showing immune complex that will be non-IgA type. Immune complex will be of non-IgA type. It will not be IgA. Usually it will be of IgG rather than IgA. So this tells you that the patient is typically having a hypocomplementemic urticarial vasculitis. Then the next disease that we need to discuss is on the cryoglobulinemia, which is very important again. Or cryoglobulinic vasculitis. So HUV, they will present the vasculitic urticaria, anti-C1q antibody, pulmonary involvement, which will be typical like LCV means leukocytoclastic vasculitis. Ashwin asking what is LCV? LCV means leukocytoclastic vasculitis. We have discussed already. Say I just want to write in short form. That's all. Cryoglobulinemia. As far as cryoglobulinemia is concerned, the name cryoglobulinemia came because these are cryoglobulins. So which means these are the proteins that are going to precipitate only on exposure to cold atmosphere. But when you take them and put under normal body warmth, that is 37 degrees C, they redissolve. They will not precipitate. So because they precipitate at cold climate and cold temperatures, they are called as cryoglobulins. So identifying cryoglobulins is very easy in a clinical side, but understanding this disease is very tough because this is a rare disease, and at the same time, you need a high degree of suspicion to find out this disease. So there are three basic types of cryoglobulinemia. One is called a type 1 cryoglobulinemia, and you have a type 2 cryoglobulinemia, and you have a type 3 cryoglobulinemia. As far as type 1 cryoglobulinemia is concerned, I can tell it as whether it's a monoclonal immunoglobulin or polyclonal immunoglobulin. Based on that only, I'm going to differentiate into 3 types: type 1, type 2, and type 3. If you ask you what is the most common type among these 3, most common type is going to be the type 2 cryoglobulinemia. Type 2 and type 3 both are called mixed. I'll tell you why. So in type 1, it is characterized by monoclonal immunoglobulins. It can be any immunoglobulin, it can be IgM or IgG, but usually it will be IgM than IgG most of the times. So, but it can be anything. Monoclonal immunoglobulins can produce type 1 cryoglobulinemia. And type 2 will have a mixture of monoclonal and polyclonal immunoglobulins. So you'll have monoclonal immunoglobulin, that is monoclonal IgM, along with the polyclonal IgG. So this IgM is supposed to have a rheumatoid factor activity. So they behave like a rheumatoid factor. So type 2 will have rheumatoid factor positivity as well, which means what is rheumatoid factor? It is nothing but a IgM or some other antibody that is direct against the Fc portion of the IgG antibody. This is rheumatoid factor. So this IgM, what you are talking about here, has rheumatoid factor activity. So that's why in these patients, the rheumatoid factor will be positive. That's why if you take the differential diagnosis of rheumatoid factor positivity, I'd have given cryoglobulinemia as one of the important differential diagnoses. If you go back and check there. And in type 3, it will be a polyclonal IgM with a polyclonal IgG. Polyclonal IgG, which means everything will be polyclonal here. So this IgM, what you're talking about here, will also have a rheumatoid factor positivity. So how can you tell? In another way also I can differentiate. So for example, this patient will not have rheumatoid factor. This patient will have monoclonal rheumatoid factor. This patient will have a polyclonal rheumatoid factor. So which means based on the rheumatoid factor activity also, I can divide the cryoglobulinemia into 3 types: type 1, type 2, and type 3. So type 1 monoclonal immunoglobulin, whatever may be the case, it will be only one type. Type 2 is monoclonal IgM with polyclonal IgG. Type 3 is polyclonal IgM with the polyclonal IgG. The IgM component is the one that's going to have a rheumatoid factor activity here. So this type 2 and type 3, because they are having a mixture of IgM and IgG and everything, so type 2 and type 3 is also referred to as a mixed cryoglobulinemia. Type 2 and type 3. Many students, the moment I tell mixed, they will ask, what do you mean by mixed essential cryoglobulinemia? Remember, if you don't have any cause for that cryoglobulinemia formation, and the patient is presenting with some disease because of cryoglobulinemia, that will be called as essential. Essential means idiopathic. Essential hypertension means we don't know the cause, clear-cut cause. It's idiopathic. Similarly, if you don't have any cause and the patient develops cryoglobulinemia, that's called an essential cryoglobulinemia. For that matter, type 1 can have essential, type 2 can be essential, type 3 also can be essential. So if it's happening in type 2 and type 3, that's called a mixed essential cryoglobulinemia, because that's a very common doubt many students will ask me whenever I finish the lecture. So usual etiologies, here I can easily tell plasma cell dyscrasias like multiple myeloma, Waldenstrom's macroglobulinemia. These are going to be the usual reasons for getting type 1 cryoglobulinemia. Type 2 cryoglobulinemia, the problem will be usually infection. It's infection related. When I talk about type 2, it's always infection. Type 1 is plasma cell dyscrasias. Type 2 is infection. You can get with certain malignancy also. That's second common cause. And third, you can get with certain connective tissue disorders. CTDs also can produce type 2 cryoglobulinemia. But the most important CTD that produces this kind of monoclonal immunoglobulins. Can you tell from yesterday, we have been talking about one CTD which is known to produce monoclonal immunoglobulins that is increasing the risk of developing non-Hodgkin lymphoma. What is that CTD we are talking about? From yesterday, I've been telling, isn't it? If you remember carefully, what is the CTD? Yes, I'm getting some answers. Of course, yes, Sjogren. So this Sjogren syndrome is very characteristic, but others also can produce. I'm not telling no, but Sjogren syndrome is very characteristic to produce this type 2, because they produce that monoclonal like gammopathy. That's why. And type 3, typically CTD related. Type 3 means it's always CTD related. Most often, this is the usual reason for development of type 3 cryoglobulinemia, but it can be due to infection. It can be due to malignancy as well. So it's a substantial overlap is there. But still, type 3 means it's CDD only. Candidate disorders, SLE, many other autoimmune disorders, MCDD, scleroderma, Sjogren, anything can produce. Type 3, type 1 plasma cell dyscrasia, type 2 infection and malignancy, type 3 CDD, that's all. What is the problem here? Here the problem is hyperviscosity. That is the problem, which means patient will not come with vasculitis. Vasculitis is not a problem here. Here the hyperviscosity is the problem, which can lead to thrombosis and infarcts. That's the problem here in this situation. So we are not actually dealing with the vasculitis in this situation. But as far as type 2 and type 3 is concerned, these are the things that are going to produce vasculitis. So what vasculitis? Immune complex vasculitis. So which means for our vasculitis understanding, your type 2 and type 3 are the important. Type 1 is not even going to produce vasculitis. Type 2 and type 3 are the ones that are going to produce vasculitis in the first place. Fine. All right. So what will be the clinical presentation? What will be the clinical features of this vasculitis due to cryoglobulinemia? That is called a cryoglobulinic vasculitis. We know the most common organ that will be affected is the skin. In the skin, typically you can get palpable purpura. You can get Raynaud's phenomenon. You can get livedo reticuli is extremely rare. You can get ulcerations. You can get nodular lesions. So any kind of skin lesion is possible, but any small vessel vasculitis, immune complex vasculitis, characteristic lesion is the palpable purpura. So that is a very characteristic lesion. And typically they can have this kind of musculoskeletal manifestations in the form of arthritis and arthralgia. That can also happen in this setting. I mean, it can happen in any vasculitis for that matters. So usually this arthritis will be symmetric and migratory type of arthritis. Symmetric, migratory, and polyarthritis. That will be the typical pattern of arthritis that you see in the setting of cryoglobulinemia. And they'll be having severe myalgia. They'll be having severe myalgia. And why I told you these three things first is because they form a characteristic feature of triad called as Melzer's triad. Even though this is a non-specific triad, the nomenclature is important because it's described for cryoglobulinemia. That's why. This is arthralgia, myalgia, which is also given in some textbooks as weakness, and they're going to have a palpable purpura. Remember, this is not specific at all. This can happen in Henoch-Schwann purpura also. This is nothing but Melzer's triad, which is typically described for the cryoglobulinemia. That's why the nomenclature alone is at least very, very important in this setting. They can have renal involvement as well. So, of course, we know what is the renal involvement they're going to cause. They're going to produce glomerulonephritis, and all the characteristic features of glomerulonephritis will be there. What is the type? Depends. Suppose if they ask you the most common type of glomerulonephritis that you encounter in a cryoglobulinemia, what will be your answer? Because all of you will be good in pathology. So you need to tell what is the type of glomerulonephritis that you will see in the setting of a cryoglobulinemia, cryoglobulinemia vasculitis. Everyone is telling MPGN, but I need to know the type of MPGN. What is the type of MPGN that you will get in this setting? Type 1 or type 2? You're a type 1 MPGN. That's very characteristic. You know, when you take HBV in exam, it usually produces MGN. When you take HCV in exam, they typically produce this type 1 MPGN. You have studied, isn't it, characteristically? So these are two viruses that produce two different types of glomerulonephritis. And that's very stereotypical questions exam. If you see HCV, they produce cryoglobulinemia. Because they produce cryoglobulinemia, you get a type 1 MPGN. Remember, but most importantly, we didn't talk about that at all. There are a lot of infections that can cause this kind of type 2 cryoglobulinemia. We didn't talk about that infection. So the most important infection of all is HCV, and the second important infection is HIV, and the third is HBV. Even though HBV is not going to be a common question in exam, they are surely going to ask this HCV. Remember, HCV is the single most important cause of cryoglobulinemia in the world. If at all somebody asks you what is the most common cause of cryoglobulinemia in the world, I will answer it's hepatitis C virus. Single most important cause of cryoglobulinemia in the world, hepatitis C virus. And they're very commonly going to produce this kind of type 2 cryoglobulinemia. That will result in the development of something called a type 1 MPGN very commonly. Clear? That's what's going to be. Apart from that, even Epstein-Barr virus can cause, cytomegalovirus can cause, even a lot of bacterial infections like streptococcus and infective endocarditis has been known to cause. Then fungal infections like candida coccidioidomycosis has been known to cause. But nevertheless, my important entity in the exam is always cryo. HCV means cryo. Most commonly, they're going to produce this type 2 kind of a cryo only, which is also the most common type of cryoglobulinemia in the world. And they can have a neurological involvement. As far as the neurological involvement is concerned, most often they're going to produce this kind of polyneuropathy. Simply, I can call it as a peripheral neuropathy. But mononucleosis multiplex is not very characteristic of cryoglobulinemia. It's more characteristic of ANCA-associated vasculitis and PAN. But in immune complex small vessel vasculitis, they don't really cause this kind of mononucleosis multiplex that commonly. And they can have a blood involvement as well. Very commonly, they will have anemia and all. And just due to anemia of chronic disease, they can have a thrombocytopenia. Possible. And ultimately, very rarely, they can have a GAT involvement. That's rare, not a common entity. GAT involvement will result in abdominal pain. Remember, but GAT involvement is very common in henoch-Schwann purpura. That's also immune complex vasculitis. But in cryoglobulinic type, GAT involvement is quite rare. And remember, these patients are at increased risk of developing non-Hodgkin lymphoma in the long run, especially DLBCL. DLBCL risk is still there. Clear? They can produce high risk of non-Hodgkin lymphoma. I mean, again, I cannot tell typically DLBCL. Suppose if it's due to Sjogren syndrome, they can result in development of this marginal zone lymphoma, that is maltoma. Again, it depends on the disease, but common disease DLBCL. Because they produce monoclonal antibodies a lot of times, so they can result in the development of NHL, high risk of developing non-Hodgkin lymphoma, that is B-cell lymphoma. Fine. So these are the characteristic features of cryo. And again, the treatment will be totally based on the type. Again, type 2, type 3, if they are going to produce vasculitis, then again, my treatment will be based on the 5-factor score. Depending on the organ involvement, I can treat with either conservative management or a more powerful immunosuppression. Again, treatment will be based on our type of organ involvement. I think cryo will be easy now. That's enough for a cryo. And which type of cryo produces vasculitis is going to be the most important. And understanding that HCV is equal to cryoglobulinemia in exam is also going to be very, very important in that setting. So cryo is over. Then the two things that are still left is Behçet's, or I can call Behçet. So very important, Behçet syndrome. As far as Behçet is concerned, it's a variable vessel vasculitis, which means it can involve vessels of any particular size. So it can involve arterioles, it can involve venules, it can involve even large vessels. So it's a variable vessel vasculitis. As far as the HLA association is concerned, very commonly asked question in exam is HLA B51 associated, or you can write as B5 also. Both are same only. That's a very common question in exam. HLA B51 associated or HLA B51 associated. Typical age group where it will be affected is 25 to 40 years. So there's a typical age group where Behçet syndrome usually happens. And Middle Eastern population are more affected. India, it's not very common. Middle Eastern population, especially the Gulf countries, are the ones that are typically involved with Behçet. As far as the clinical features are concerned, I can give as a part of a triad. One is the recurrent aphthous ulcers. That's more important. Recurrent aphthous ulcers. Remember, aphthous ulcers, you know, they're going to have that kind of a necrotic base, that white color, that like that exudate will be there. So that's typical of aphthous ulcers. That's the first finding. And second finding will be that of vasculitic picture. Vasculitic picture. And third finding is that of a Pethergy test. So Pethergy positivity. So that's how I'm going to divide Behçet's into. So recurrent oral, I mean, aphthous ulcers can happen in the oral areas or can happen in the genital areas. In the oral areas, I mean, they'll be usually large, recurrent, and excruciatingly painful. And any aphthous ulcer, you know, it's going to be excruciatingly painful, especially if they are large and coming in unusual areas like pharynx, the back of the tongue. So they are going to literally kill you. You cannot eat anything. So it's a very painful condition, aphthous ulcer. And you know, aphthous ulcer are going to have a necrotic base. That's going to be more important understanding. As far as genital ulcers are concerned, the location is very important. In females, the location will be usually in the vulva. That's usually most common site. But in males, the location is going to be in the scrotum. You know that scrotum is the modified vulva in males. And it can happen in the shaft of the penis but happening in the glands of the penis is extremely rare. You don't really get in the glands that commonly. So this is the location of these aphthous ulcers, and remember they are recurrent, extremely painful ulcers. And as far as the vasculitic feature, as far as the pathology is concerned, let me finish off the pathology first. Pathology is concerned, this is a very peculiar thing. Sensitivity is variable, maybe around 25 to 40% sensitivity, but it's very specific. In Asians, they have a very high specificity compared to Caucasians, especially Middle Eastern population are known to have high sensitivity. They are the ones who show maximum pathology positivity, that Gulf countries, Mediterranean countries. So they are the ones who produce maximum Behçet positivity. But when you come to the Asian side, when you go to the Caucasian side, the sensitivity will be less and they won't show that much. So the overall sensitivity is around 25 to 40. What is pathology? It's very, whenever they tell pathology, it's always Behçet. That's all in exam. So there will be a pinprick kind of a trauma that you need to give. Whichever point that you give pinprick, that point will become papules within 24 hours. Within 12 to 24 hours, you will develop papules in that area. So this is typical pathology. And this kind of pathology positivity can be indirectly told in exam. For example, they will tell around the IV cannula sites, around the Venflon sites or around IV cannula sites, you are seeing these small papules that are originating. If they tell like that, that is also a sign of a pathology in exam. So don't get confused with that, thinking that it's some cutaneous condition. So there could be some vasculitis features. For example, the number one is the eye involvement is quite common in Behçet. So, for example, they can produce scleritis, they can produce episcleritis, they can produce uveitis, they can produce retinitis. Retinal involvement is quite common, and retinal vasculitis is very common, which can involve in blindness. So they can produce optic neuritis also, which can be vision threatening. Remember, in this, the uveitis is something very commonly asked in exam. Usually this uveitis will be a post-uveitis than an anti-uveitis compared to HLA-B27. And this will result in typical hypopyon formation. The post-uveitis is the one that produces hypopyon, isn't it? That pus level, it's hypopyon formation. That's characteristic of post-uveitis. So that is one thing that will be asked in exams. Very commonly, vasculitis with hypopyon formation. Think about Behçet. And apart from the eye involvement, they can have the characteristic skin lesions, which is very important to know. So usually I used to remember by the mnemonic called SAVE-P lesions. This is a mnemonic I generally used to use in my undergraduation, like you all. I was very fond of mnemonics those days. Nowadays, I'm not, absolutely. So S stands for pseudo follicular lesions. And A stands for acneiform lesions. This is something very commonly asked in exam. Acneiform lesions in the skin usually can be a evidence of Behçet. And V stands for vesiculobullous. Because Kawasaki never produces vesiculobullous lesions, they very commonly tend to confuse you with that. E stands for erythema nodosum. This is the most common type of skin lesion to be seen in Behçet. We know how erythema nodosum looks like. I showed you already. P stands for pyoderma gangrenosum. Again, this is the lesion which I showed you already. So these are the skin lesions that you can get in the setting of Behçet. Apart from that, they can develop a variety of other problems. Neuralgia and arthritis, they can develop. Number 4, CNS involvement, neurological involvement can happen in certain patients. And finally, the vascular involvement is again very characteristic. Especially in the vascular, venous involvement is very characteristic. In exam, this will be the usual question. So as far as the venous involvement is concerned, they can produce superficial thrombophlebitis as well as deep vein thrombosis. Superficial thrombophlebitis and DVT, deep vein thrombosis also. Remember, any vasculitis can produce a DVT, including vaginous, as high risk of producing DVT. But if you get DVT with characteristic oral ulceration, aphthous ulcers, so it's always a Behçet, nothing else. That's all. You cannot do anything else. This is always Behçet only. And they can have arterial involvement also. In many areas, they can go for arterial stenosis of medium to large vessels and arterial occlusion, aneurysms. All are possible with Behçet's. So very characteristic. So you can get like any kind of feature. So this is a vasculitic picture I want to tell. So at least one vasculitic picture will be there in exam, and definitely they'll give aphthous ulcer. Pathology may or may not be there. So this is how you basically diagnose a Behçet in exam. Fine. All right. So what are the keywords in exam to diagnose Behçet? The post uveitis causing hypopyon, acneiform lesions, deep vein thrombosis, erythema nodosum, pathergy positivity, and aphthous ulcers. These are the keywords. These are the trigger words in exam to diagnose Behçet in reality. Investigation wise, it's very difficult to prove that it's a Behçet. Commonly, like one of the important differential diagnoses, herpes simplex virus encephalitis, because that also can cause something like kind of a recurrent kind of an ulceration in the mouth. So, I mean, if you really want to differentiate, because that also produces genital as well as oral ulcerations. I mean, HSV complex, that is HSV1 especially. So if that is the case, then you have to take a swab and you have to do a HP in that, and you have to prove that the patient is not having any transformed cells. That cytopathic effect is not there, which is typical of herpes simplex virus. So swab may be needed sometimes too if you want to have a differentiation from herpes simplex virus, because it's a close differential diagnosis. Apart from that, there is no much investigation that the ESR CRP can be evaluated, which is absolutely non-specific. And what about treatment? Treatment again is difficult to treat. I mean, depends on the severity of the disease. If it's only ulcers, which is a major problem for the patient, you can manage, like conservatively, like you can give colchicine, which works better. You can use topical steroids. If it's only ulcers or skin problems, that's going to be the problem. I mean, most important thing, you can treat with colchicine or topical corticosteroids. Even dapsone works decently here. Apremilast, which we have used in psoriatic arthritis, that is phosphodiesterase 4 inhibitor, works to a decent level. Suppose if arthritis is your primary problem, then I can use again colchicine, but not topical steroids. I'll be using systemic steroids, and I can use NSAIDs for arthritis. In severe organ involvement, if the patient is having neurological involvement or any other severe organ involvement, I have to go for a disease-modifying drug like anti-TNF-alpha drug, cyclophosphamide, azathioprine. I have to go for additional immunosuppression if it's a severe disease. Apart from that, I need not use this disease. I can just manage conservatively till I attain remission. But there is no typical treatment. But in exam, if you want to go for one typical treatment for ulcers, if they ask you, you can go for colchicine and topical steroids. This is what the usual question you will get in exam. Apart from that, other things are very rare to get. Okay, this is typical Behçet. So I think we have covered about almost all the vasculitis that is important for exams. I don't think there is any other need for vasculitis to be covered. And finally, before moving on to the other forms of disease, let us finish off the amyloidosis as well, because amyloidosis is something that will keep on coming again and again. So let us finish off that also in this particular session itself. It needs hardly 10 minutes. Amyloidosis. Amyloidosis basically I can divide into two. One is called the primary and secondary forms of amyloidosis, or localized forms of amyloidosis. I can tell 3 different types. So basically, primary forms of amyloidosis will be made of AL type of amyloid, and secondary forms of amyloidosis will be made of A type of amyloid. And there are many other localized forms of amyloidosis like Alzheimer's disease, where you have only A beta amyloid that is present in the brain, or in thyroid cancer like MTC, the amyloid will be only in the thyroid. That's called calcitonin amyloid. So how will you differentiate? First, you have a systemic amyloidosis. You have a localized amyloidosis. So as far as systemic amyloidosis is concerned, I can tell primary amyloidosis, secondary amyloidosis, then you have a TTR based amyloidosis. As far as primary amyloid is concerned, it's typically of AL type of amyloid. Secondary amyloidosis, it's AA type of amyloid. TTR type of amyloidosis, again, it has 2 types. One is called the familial TTR type, and the second one is the senile systemic amyloidosis. I can write as SSA. SSA stands for senile systemic amyloidosis. Clear? So typically, in familial amyloidosis, there will be a mutated TTR, mutant transthyretin will be there. TTR stands for transthyretin, and in senile systemic amyloidosis, there will be a normal TTR that is getting accumulated. That's called a wild type TTR. Normal TTR will be accumulating here. Localized amyloidosis, you have many more types are there. As far as localized is concerned, you have number 1, Alzheimer's disease, where you have A beta kind of amyloidosis, where the deposition will happen only in the brain. As far as second is concerned, you have medullary thyroid cancer, where you have an amyloid called calcitonin amyloid that will be depositing only in the thyroid. Then third, you have type 2 diabetes mellitus, where you have pro-IAPP. There is something called IAPP amyloid. That's called islet associated polypeptide. So that will be depositing only in the beta cells of the pancreas. Beta cells of the pancreas. It can get deposited only in the heart also. I mean, sometimes in chronic volume overload states, that's called a ANP type of an amyloid. That is also there. But these are the usual examples of localized forms of amyloidosis. So it can happen in 3 conditions called classical Alzheimer's disease, MTC, and type 2 diabetes mellitus. On the other hand, systemic types of amyloidosis can affect multiple organs. I mean, depending on the type of amyloid. AL can affect certain different types of organs. AA can affect certain different types of organs. For example, what are the diseases that cause this AL type of amyloidosis? Even though it's called a primary type of amyloidosis, AL is typically made of monoclonal immunoglobulins only. So typically, I'm going to see this kind of amyloidosis in a monoclonal gammopathy or any plasma cell dyscrasia. That will be a right answer. Any monoclonal gammopathy or plasma cell dyscrasia, I can see this kind of amyloidosis. It can be primary also, but typically I will get in a plasma cell dyscrasia. Idiopathic is also possible, but that's very rare. As far as A type of amyloidosis is concerned, usually that is an amyloid that is seen in chronic inflammation, as I told you. I think one of you have asked the doubt regarding what is the amyloid that we'll see in this particular type. It's a serum amyloid A protein. The serum amyloid A is the one that is getting accumulated, that is causing the AA deposition. So typically it happens in the setting of a chronic inflammation. Any condition that produces chronic inflammation. For example, rheumatoid arthritis, tuberculosis, bronchiectasis, very common questions in exam. Then it can happen in the setting of an inflammatory bowel disease. Clear? So these are the usual conditions that results in the development of A type of amyloid and subsequent amyloid deposition. As far as the mutant TTR is concerned, it is basically a hereditary form. And usually they will affect the heart only, but I'll tell you there are some variations are there. Neurologic and cardiac management will be the common. Normal TTR, it's a normal part of old age. Normal part of old age. That's all. Now you have specific organs that can be involved. Remember, as far as the AL type of amyloid is concerned, almost all the organs can be involved. I mean, that are typical for involvement in amyloidosis. Typically, they can produce renal involvement. Typically, in the kidneys, you will get nephrotic syndrome. They can produce cardiac involvement. They can produce restrictive form of cardiomyopathy. We know that. They can have GA involvement, which can result in malabsorption. Then they can produce neurological involvement, producing peripheral neuropathy and autonomic neuropathy, causing erectile dysfunction, all this stuff. They can produce skin involvement, producing this kind of amyloid purpura. Or they can have hepatosplenomegaly as well. Everything, whatever possible, can be caused by this AL type of amyloidosis. Fine. As far as the AA type of amyloidosis is concerned, the most classical feature of AA type of amyloidosis is the renal involvement, producing nephrotic syndrome. That's the most classic. Even though they can produce GAT involvement causing malabsorption, they can produce hepatosplenomegaly, and they can produce cardiac involvement as well. But cardiac involvement is very classic in one disease, that is familial Mediterranean fever, FMF. Very commonly they will ask. The most common cause of death in familial Mediterranean fever is again cardiac involvement only. Everyone knows that the familial Mediterranean fever is due to mutation in the pyrin gene, which is in the auto-inflammatory pathway. So FMF, most common cause of death, is cardiac involvement only. I mean, other than that, cardiac involvement in other diseases are quite rare. So I can add another disease here, that is familial Mediterranean fever, FMF. I can add another disease here. But cardiac involvement is not that classic in this situation, but in FMF, familial Mediterranean fever, you can get cardiac involvement, which is the common cause of death. In FMF, if they ask you what is the type of amyloid you have, again, it is a AA type of amyloid only. As far as your TTR-based amyloidosis is concerned, TTR-based amyloidosis, the prominent involvement is the cardiac involvement. So usually cardiac involvement is going to be the prominent as far as TTR forms of amyloidosis is concerned. But this familial varieties have two types. One, they have cardiac involvement. Second, they have a neurological involvement. So some patients will have, with familial forms of TTR amyloidosis, they will have neurological involvement alone. That's called a FAP. That's called a familial amyloid polyneuropathy. That's called FAP. That's also a question. So familial amyloid polyneuropathy is due to which amyloidosis, amyloid deposition. That is a transthyretin amyloid. It's the familial type of amyloidosis. They can have only neurological. But cardiac involvement is common in both, like types of amyloid. Familial or senile, doesn't matter. They can have a cardiac involvement. Not a problem at all. And finally, one important type of amyloid is there. That is a separate one. That is called dialysis-related amyloid. Everyone would be heard about that. Dialysis-related amyloidosis. Typically, this is due to accumulation of beta-2 microglobulin. Everyone knows that. This is the reason why you get this dialysis-related amyloidosis. And one of the important clinical feature for this dialysis-related amyloidosis is this kind of shoulder arthritis. Shoulder arthritis. Shoulder arthritis is the classical manifestation of a dialysis-related amyloidosis. If any patient on long-standing dialysis coming with shoulder pain, think about a beta-2 microglobulin-related amyloidosis causing problems in this setting. So now let us see what will be the classic manifestations of each and every entity. Renal, usually they will manifest as nephrotic syndrome, not always, or they can present with a non-nephrotic proteinuria also. Either nephrotic proteinuria or non-nephrotic proteinuria, but the classical presentation is proteinuria. That's more important. Significant proteinuria will be there. That's the more important thing rather than nephrotic or non-nephrotic. But typical description in textbooks is nephrotic syndrome. Cardiac, they produce restrictive cardiomyopathy. We know that in echo, we also saw that it will produce something called a sparkling appearance. And we already discussed in detail about what is this restrictive cardiomyopathy. As far as GI involvement is concerned, they produce malabsorption as a major finding. And as far as the neurological involvement is concerned, it can be anything ranging from polyneuropathy to autonomic neuropathy. And remember, one of the important causes of autonomic neuropathy or predominant autonomic neuropathy is amyloidosis, where they can result in erectile dysfunction. That's what I'm trying to tell. And in skin, they will produce these sort of waxy papules, amyloid purpura, and they can produce macroglossia. These are the trigger words in exam: waxy papules, amyloid purpura, macroglossia. And of course, they can produce hepatosplenomegaly as well. Here, understand renal, GI, HSM, cardiac, dialysis produces shoulder arthritis. Typically, cardiac in transthyretin, special form of familial TTR-based amyloidosis, that is familial amyloid polyneuropathy. And the localized forms of amyloid, we are talking about Alzheimer's disease, MTC, and type 2 diabetes mellitus, where IAPP is the amyloid in case of type 2 diabetes mellitus. That is called islet-associated polypeptide. That's all. Is there any treatment really for amyloidosis? Remember, amyloid, what are the characteristic features of amyloid? You would have studied in pathology. If somebody asks you the features for amyloid, you will clearly tell that they are extracellular in location, typically, and irreversible deposition. Once deposits are happening, it is completely irreversible. You cannot remove back. And in HPE staining, they look eosinophilic. And they are arranged in beta pleated sheets. That's how they are arranged in beta configuration. They are fibrillar in nature. And when you stain with Congo red, they will stain red, basically. And these red stained areas, if you take for polarized microscope, they are going to produce something called apple green birefringence. Apple green birefringence, that's all. Is there anything else you want to add? I mean, whatever I know I have told, but is there anything else that you know that you want to add as far as amyloid is concerned? Because you would be much better in pathology, I guess. These are typical features of amyloid. Anything else there? Yeah. Elemental told one more point, that's correct. Electron microscopy can show infinitely long fibrils. But not infinite, of course, but in that context, it's infinite. Anything else? Okay. Nothing else. Nobody's telling anything else. Okay. So these are the characteristic features of amyloid. They will ask you how to diagnose. What are the investigations you can use? Investigation typically based on, like what is the underlying pathology. Based on that only you do investigation. For example, if you think about an AL type of amyloid, you have to find out the monoclonal chain. So serum protein electrophoresis or urine protein electrophoresis may be the key there. If you think about a AL type of amyloidosis, or if you're thinking about the AA type of amyloidosis, usual key will be to find out the proteinuria. That nephrotic syndrome is very important, which means I can do a kidney biopsy. Even AA or AL, I can try doing a kidney biopsy. In kidney biopsy, I'll be seeing that amyloid. All amyloids will be staining for Congo red. And once it stains for Congo red, and if it's apple green birefringence, then Congo red positive means it is going to be amyloid only. And next step is to find out whether it's AL or AA. So I'll be doing light chain staining. Light chain staining has to be done with kappa chain, lambda chain. If it is positive, I can go towards AL type of amyloid. If it is negative, I'll talk about a AA type of amyloid. Very simple. There is a white strip in the screen. Please remove. Is there any white strip in the screen? I don't know where is the white strip. I think you're talking about my figure, which is the white strip. Where is that white strip? Is it gone now? Gone or not gone? Okay, gone. Cool. Okay. So I'm going to use a gamma chain, kappa lambda chain staining. So if it is positive, then I'll go for AL type of amyloidosis, and if it's negative, I'll be thinking about a AA type of amyloidosis. So whenever you have a renal involvement, you do a kidney biopsy. Kidney biopsy if there is renal involvement. Suppose if you don't have a renal involvement, then probably another investigation that you can try is biopsy from different areas, especially if you have a systemic amyloidosis. In that setting, I can do a abdominal fat pad biopsy, or I can do a rectal biopsy. Of course, you would have, been very clear about this. Abdominal fat pad biopsy is more sensitive compared to that of the rectal fat pad biopsy. And in this setting, you will be seeing the amyloid deposition. This is, very good if at all you are having a systemic type of amyloidosis. If it's having a systemic type of amyloidosis, this can be a good option, doing an abdominal fat pad biopsy. Or alternatively, in any systemic forms, you can do from the particular organ itself, organ of involvement. You can do biopsy from that particular organ of involvement. For example, as I told you, from the kidney, you can do if it's nephrotic syndrome, or from the heart, endomyocardial biopsy can be done, but even though it's not done routinely. But if at all they ask you a non-localized site for systemic amyloidosis, you can do abdominal fat pad biopsy. That's one option that you can do. So treatment-wise, again, there is not much to tell about the treatment. As far as AL type of amyloidosis is concerned, you have to treat the plasma cell dyscrasias. As far as the AA type of amyloid is concerned, you have to treat the disorder that is causing this chronic inflammation. Like you have to treat the rheumatoid arthritis to make it to go for remission. You have to treat the IBD. You have to treat the familial Mediterranean fever. So something you have to do. But for TTR-related amyloidosis, there has been a substantial research has been done. So treatment for TTR-related amyloidosis, there are some 2-3 treatment options that are available. One is the liver transplantation. They have told like liver transplantation works a little bit because liver is the site of production of this abnormal TTRs, mutant or high level of TTRs produced by liver transplant. So for hereditary conditions, liver transplant might be useful. So once you transplant the liver, they produce normal TTRs from now on. Or there are some drugs that can be helpful in destroying this TTR or reducing the TTR production from the liver. Like for example, you have drugs like patisiran, or another drug called inotersen is there. These are going to act basically at the genetic level. For example, patisiran is a small inhibitory RNA. It has siRNA, whereas inotersen is a antisense oligonucleotide RNA. It's an antisense oligonucleotide. So how this works? This is quite simple. We know something called a central dogma of biology is there, where you have the DNA, which is going to become mRNA, which is going to become proteins. So here the TTR protein, this is the dangerous one. TTR is the one that's creating an issue here. This is the one that is creating issue here. So what we are trying to do here is you give either a siRNA. So let us assume this is a small interfering RNA. If you give an siRNA, you form a double-stranding RNA inside the cell. And whenever the cell sees the double-strand RNA, that particular RNA will be destroyed, because as per our evolutionary code, double-strand RNA means it's virus only and they will kill them. The cell will not leave the double-strand RNA. So you will not result in the development of the TTR protein at all in the first place. Second way is you can give a similar small antisense oligonucleotide. So they work by the same principle. Only the strand length will be difference. Oligonucleotide will be a little longer than the small interfering RNA. So only the strand length will differ, but apart from that, both are working with the same mechanism. Once you form the double-strand RNA, it will be destroyed before they form the protein. That's why you can reduce the TTR production. So that is patisiran and inotersen. Both these are there. And third is something called a tafamidis is there. Basically, this is an NSAID compound. This is a non-steroidal anti-inflammatory drug that is going to stabilize the TTR tetramers. So they stabilize the TTR tetramers. That is tafamidis. And patisiran and inotersen, they generally tend to reduce the TTR production. That's all. So investigation-wise, you can either select a localized site for biopsy. Typically in nephrotic syndrome, we choose kidney. Or in the setting of a systemic amyloidosis that is not involving the kidney, then in that setting, you can select a very localized site like heart, or probably any other site which is involved, you can select. Or if you want to select one common site, you can select abdominal biopsy or abdominal fat pad biopsy, or you can do a rectal biopsy. In that, we know that abdominal fat pad biopsy is going to have a higher sensitivity and specificity compared to the rectal fat pad biopsy. So that's why choice is abdominal fat pad biopsy only. In that area, same principle, you take a biopsy and put it on a Congo red stain. If it stains red, it's a amyloid only. And put it under polarized microscope, you're going to see apple green birefringence. That's all. So this is how you diagnose an amyloid. So either you can take from a specialized site, depending on the organ of involvement, or take from an abdominal fat pad biopsy. These are the two options that you have for diagnosing amyloidosis. But treatment, depending on the cause. Systemic amyloidosis, if it's AL, treat multiple myeloma if it's the case. If it's AA, treat the chronic inflammation if that is the case. TTR, you have a variety of treatment options. Liver transplant, the two genetic level manipulators like that patisiran and inotersen is there, or you can give tafamidis, which is an NSAID that stabilizes the TTR tetramers. So localized, you cannot do anything. Localized, nothing can be done. So that's a disease process, and there is no treatment option available to reduce the localized forms of amyloidosis. I think with this, we have completed the entire rheumatology. There's nothing else that is left in rheumatology right now. We have covered almost everything, whatever is possible today. I think from the next session, we'll be starting with kidneys, nephrology. Let us close down the rheumatology with this itself. I think enough is enough. We'll move on to the nephrology from the next session. You can go have a break and come back at 8:15. Bye.